see I get it, bend, then you get it, then you see I can bend, then you get it, then you see I get it, bend, then you get it, then you see I do bend, then you get it, then you see I get it, bend, then you get it, then you see I can bend, then you get it, then you see I get it, bend, then you get it. Then you'd see I do bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I come bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I do bend, then you bend. Then you'd see I bend, then you bend. Then you'd see I do bend, then you bend. Then you'd see I bend, then you bend. Then you'd see I do bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I come bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I do. See, I get it, bend, then you get it. Then you see, I bend, then you get it. Then you see, I get it, bend, then you get it. Then you see, I come bend, then you get it. Then you see, I get it, bend, then you get it. Then you see, I do bend, then you bend. Then you see, I bend, then you bend. Then you'd see I could bend, then you bend. Then you'd see I bend, then you bend. Then you'd see I could bend, then you bend. Then you'd see I bend, then you bend. Then you'd see I could bend, then you bend. Then you'd see I bend, then you bend. Then you'd see I could bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I come bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I do bend, then you get it. Then you'd see I get it, bend, then you get it. Then you'd see I come bend, then you get it. Then you'd see I get it, bend, then you get it. All this panic, see, I get it. Panic, get it.
Mic check. Mic check. Check. check, check, mic check, 1, 2. Check, mic check, 1, 2, mic check, check. Mic check, 1, 2, 1, 2, mic check. Mic check, mic check. Mic check, 1, 2, mic check, mic check, mic check, 1, 2, mic check. Mic check, 1, 2, mic check. Mic check, 1, 2, mic check. Mic check, 1, 2. Mic check, 1, 2. Mic check, 1, 2. Turn it up a little bit. Mic check, 1, 2. Mic check. Okay. Mic check, 1, 2. Mic check. Mic check, 1, 2. Mic check, 1, 2. Mic check, 1, 2. 1, 2, mic check, 1, 2. 1, 2, mic check, check, mic check, 1, 2. Mic check, 1, 2, 1, 2, mic check. Mic check. Mic check, 1, 2, 1, 2, mic check. Sit down now. Mic check, 1, 2, 1, 2, mic check. Mic check, 1, 2. I need some more volume on this one. Mic check. Mic check, 1, 2. Mic check, 1, 2. No. No. This one's plus 15. This one's plus 9. This one is plus 9. Number 2. Mic check, 1, 2. Mic check, 1, 2. Yeah. Yellow. Good morning, everybody, and welcome to the Sunday morning presentations. And we're going to get started with Jason Newton. He's the general counsel for what used to be Medical Mutual, which is now called Curie since 2019. The good news, he understands us because his dad was a gastroenterologist, and he's going to give us a fascinating talk about some of the legal updates, and I think you'll really enjoy this lecture. Welcome, Jason. And then this will.
Got it. Thank you.
We're just trying to.
Okay. We're waiting on the
There it comes.
confidence monitor here. Okay, we got it. Good morning. Thanks for taking time to join me. I'm sorry if I spoil your breakfast, but I tend to have that effect on people when I talk. So there's your disclaimer. In addition to this one, I don't have any conflicts. Obviously, I work for my employer. Hopefully what I'm going to tell you today will be helpful, but I'm Curie's lawyer. I'm not your lawyer. So this isn't legal advice. I'm not giving any endorsements for any logos or companies that appear on my slides, and there are no guarantees that anything I say would prevent you from experiencing a claim or bad outcome or mitigate a bad outcome. So, we lost the signal here. Okay, well, I'm going to keep going because I can see enough here. So this is data from around the country. It's national data. It's not Curie's data, and it illustrates what we call severity in the country over the last 20 years. And I've just picked out the $10 million and up medical malpractice verdict data. And you can see on the far right-hand side, excepting 21 and 20, when courts were shut down due to the pandemic, the prior 4 years through 2022 had the largest number of $10 million and up medical malpractice verdicts, okay? 48 in 2022, 52 in 2019, et cetera. So what happened in 2023? There were 57 $10 million and up verdicts. And if you looked at 10 million, you pick your number, 1 million, 50 million, you know, all the trends follow this graph. But 57 in 2023, and I just wanted to provide you a little granular detail in terms of where these are happening to illustrate the point that Cook County, of course, yes, it is on the list, but so are other places where these types of verdicts have not been seen before. Also to illustrate that I've picked out $10 million and up verdicts, but we're now seeing verdicts over $100 million. And the saying in the industry, which some people don't like, was that these are nuclear verdicts. How do you describe what's happening here? Some people call them aberrational. But with the advent of verdicts now popping up for over $100 million, pundits have found the need to come up with a new term and call those verdicts, $100 million and up verdicts, thermonuclear verdicts. So that's the state of the landscape today. And, you know, whatever you choose to call them, I do want to reassure you, these happen in the extreme minority of cases that are tried. But they do drive up the price of poker in future cases. There's a saying that verdicts drive settlements. And so plaintiffs' lawyers, when they see a big verdict, you know, they point back to that as to increasing the value of their case. What's going on behind this trend of large verdicts? You know, there's social inflation. There's no COVID hero effect for healthcare providers. That's pretty clear. There's so many things going on. That would be a separate presentation. But a good thing for you is that you're in North Carolina, and you'll notice that on this list of the ones that I've just picked out here, we don't see any $10 million and up verdicts in North Carolina. Why is that? Well, most of you probably know you live in a state where you have the benefit of a non-economic cap on damages. Okay, that means pain and suffering, soft type damages. There's a hard cap of roughly $600,000 that governs those. And there's also, perhaps more importantly, coming out of the tort reform that was passed in 2011 in North Carolina, the ability for one party to request and require that the case be bifurcated. What does that mean? It means that the liability phase is separate from the damages phase. So if a jury finds against a healthcare provider in North Carolina on liability, then the case would go to a second phase where damages would be determined. Why is that so important? It's because it provides an opportunity for the defendant and the defendant's insurer to settle the case within policy limits, as opposed to leaving to chance what the jury might do. So you live in a good state for medical professional liability. What do you do about that? Well, you pay attention to and you be informed about statewide appellate judge races. Okay, that's the Court of Appeals and it's the North Carolina Supreme Court. If you go into the voter booth this fall and in future elections and you have no idea who you're voting for when you get down ballot on those races, that's a problem. Okay, you need to understand who might be favorable to supporting medical professional liability, because the plaintiff's lawyers, I can assure you, are just waiting for the opportunity to get a test case in front of those judges, and those are the courts that will hear challenges to the tort reform that's been in effect since 2011. Okay, so I'm going to try to call out action items for you. That's one. Be informed when it comes to statewide appellate judge races. And secondly, you need to seek out protection when it relates to your assets. We at Curie have a number of different business lines. One of them is insurance, one is wealth management. It's now called Curie RMB. I'm not telling you we're the source, the sole source. There's plenty of people that can provide you this type of advice. There are perhaps other wealth management advisors. There's debtor, creditor attorneys who can help you with this. But if you don't have your asset protection locked down before you know about a claim or should have known about a claim, then you're going to be trying to insure a house that is already on fire. You can't do it, okay? So it's very important, and I normally tell people who are coming out of training or about to come out of training, like, this is thing one that you do when you start to earn income. And it's okay if you haven't done it, but you need to do it, and you need to do it soon, particularly because of the severity trends that we're seeing here. I do want you to understand that getting higher limits for your medical malpractice insurance is not the answer. Okay, you want to be market standard. You don't want to have outsized limits, and then become a target for plaintiffs' lawyers because of the large pocket of insurance that you've got. And I do also want to make the point that umbrella insurance is important when it comes to non-medical exposure. You know, you as physicians are known to be a group that is financially well off, and it doesn't necessarily have to be medical malpractice where people are going to be trying to get at your hard-earned and well-deserved assets. Okay. And if you don't have asset protection, you can see an example here in Washington State where there was a physician who had a $13 million verdict against her and attempted to try to do some of that insuring the house that was on fire, and got called out on it and challenged by it. So, all right, what's the good news behind all these depressing things that I'm talking about? Well, roughly 85% of all medical professional liability cases that go to trial are won by the defense. That's good, right? We win most of the time. These aberrational verdicts, as I've said, they make up an extreme minority of cases that are actually tried, and some of them are overturned. There was a verdict of $229 million against Johns Hopkins in the summer of 2019 involving a catastrophically injured baby. In that case, after 2 or 3 years of appeals, was totally overturned, completely wiped off the books. So, you know, there is hope after a large verdict that things can get reasonable, but it certainly is an uphill battle. And then also roughly 12 to 14% of, this is Curie data now, 12 to 14% of all claims and suits that come to us for our insureds require a payment to the patient or the plaintiff. Okay, so extreme small number of payments that we're making for all the suits and claims that we're getting in. The national data, the most recently available data, would be 26 to 30% of the time a claim or suit presents, then a payment would be made to the plaintiff. Smaller numbers actually better. We're proud of that statistic at Curie. All right, now getting to a state lines discussion. So recently we've seen some questions about apps that are designed to provide specialty curbside consults to primary care physicians, but also others. And there are a number of them out there, and I've listed a few here. You can think of this as Uber for specialty consults. I don't know if any of you have heard of these types of apps by chance, but they are making a push in North Carolina. I'm not seeing any hands. And, you know, in my experience, these have cropped up during COVID, where the shackles were off, if you will, when it comes to payers, when it comes to regulations, et cetera, et cetera. And, you know, folks that are behind these, I know they're trying to do good things, but to the extent they tell you that what they're providing you is anything other than telehealth, that's where we have a disagreement. So I would channel your inner Juliet Capulet and consider it to be telehealth, regardless of however else it's characterized to you. And, if you're planning on engaging in one of these services, you need to carefully read and understand what I would characterize as click wrap, non-negotiable terms of service that are fine print on a website, just like everything else, that if you're engaging with something, you just click accept, accept, accept. Okay, let me get to the app. This is what it says, and it's important. Here's one that purportedly puts all the liability for any bad outcome squarely onto the provider who is seeking the consult, stating that the provider who provides the consult has no responsibility whatsoever. That might be okay for you if you're the GI providing a consult to the primary care physician, but think about if you're engaging with the app to seek out a specialist yourself or subspecialist. Here's another one that purportedly says the service makes no representation or warranty that the consults provided are or will be reliable, accurate, complete, secure, timely, or error-free. Okay, yep, that usually gets some chuckles. And then finally, here's another one that purports to say that doctors who seek consults using this service must unilaterally indemnify the app and its agents for any liabilities, claims, damages, including but not limited to third-party claims related to negative patient outcomes or medical malpractice. So let me ask you, if you called a subspecialist and you were asking for a curbside and they just read you what I just described to you, click, no thanks. I'll call somebody else who doesn't require that. This is important stuff. And so if you're thinking about engaging in this type of technology, which again has its use cases and might be beneficial eventually, I'm finding doctors are forgetting the elementals and forgetting that, COVID is the pandemic and the loosening of those restrictions. That's over. And you have to, consider the old rules when you're thinking about engaging in these things. So the thing that sort of rises to the top of my mind is, do you have the appropriate licenses to provide consults in other states? And do the consults that you're seeking out, do those people, those licensees have a license in the state where the patient is physically located? That is, in fact, the rule. Okay, you have to be licensed in the state where the patient is physically located at the time you're providing any treatment. And time again, when I'm presenting to physician audiences, that's like I'm saying a new thing. People didn't realize that, particularly for people who live in Charlotte, live near the border of Virginia, et cetera. Now, there are some gray areas behind that. We might get into that on the panel discussion a little bit later. But to illustrate my point here, one thing is you might find yourself unwittingly sued in a state where you don't practice. And there was an example of that in 2022. This didn't involve one of these apps, to be clear, but it did involve telehealth. We had a North Carolina doctor providing a consult into a patient who was in Virginia. There was a bad outcome. There was a medical malpractice suit filed in Virginia federal court. Doctor says, whoa, I didn't mean to avail myself of the jurisdiction of the Commonwealth of Virginia. Please, court, dismiss the case. Court said no. Doctor said, okay, can you transfer the case for convenience for me to a federal court in North Carolina? Court said, no, you're going to face suit here in Virginia. What are the potential problems here? If the North Carolina doctor doesn't have a license in Virginia, that's a problem. Okay, it's a problem with the licensing agencies, and it's a problem for a medical malpractice policy, because no medical malpractice policy in the country affords you coverage in a state or environment where you are not licensed to practice medicine. Now, even if this doctor, as it turns out, was licensed in Virginia, but perhaps he has a medical malpractice policy that's based on market standards in North Carolina. Let's say in North Carolina, usual policies are $1 million in coverage. Virginia has a hard cap on all types of damages of like $2.6 million now. So that's good. A hard cap on everything is really good. That may be subject to change in Virginia, but that's another story. So what happens with a doctor who has $1 million policy limit who is sued in Virginia where the cap is $2.6 million? There's a potential gap in coverage, right? You've only got $1 million in coverage. That's if it applies. And then you've got a $2.6 million cap. So these are the types of things, when I'm talking about fundamentals, you can't just go after the shiny new object and think because it exists, it must be okay. You've got to do the due diligence on your own. Okay, and so we did provide a resource because we were getting questions. We had concerns about this that we published and got the QR code for you, and it's in the slide. So I would encourage you to take a look at that white paper. All right, what about really virtual consults? will we be getting care from chatbots in the future? I think the answer is no. They won't be our future doctors. But AI, generative AI, or augmented intelligence at least, will or is involved in medical care now and will be in the future. And it is fascinating to see. Chatbots can pass the bar exam, in the 90th percentile. They can pass the LSAT in the 88th percentile. They can pass the perhaps the toughest of all tests, the Advanced Theory Sommelier course, to the tune of 77th percentile. So if you need wine advice, maybe that's a good reason to go use ChatGPT. Clinical care, not so much, okay? But if any of this is causing you heartburn or concern, don't worry, because Elon Musk says he's sure everything is going to be fine. All right, so are your clinicians, don't answer. Anybody out there using ChatGPT in the clinical care setting, please don't. It's not confidential. It's not a closed loop system. You ought not to be putting confidential information into ChatGPT. Additionally, as you probably have heard Sam Altman say, ChatGPT, like other AI, is hallucinating, okay? It's not providing you sentient information. So let's not confuse it for something that it's not. And there was an interesting article in the New York Times actually almost a year ago, where a North Carolina doctor described to the ChatGPT, the complex medical history of a patient that he saw, and talked about the complications and asked how he should have treated the patient. And he said ChatGPT basically gave advice that was exactly how we treated the patient. I would say coincidence, okay? Not something you need to rely upon. I'm going to provide you some examples of flaws when it comes to asking ChatGPT clinical questions. So one of my favorite, I'm a recovering malpractice defense lawyer, okay? That's where I spent my life for 14 years, was defending healthcare providers in North Carolina. One of my favorite tricks, everybody hates lawyers until you need one, right? So one of my favorite tricks when I was cross-examining plaintiffs' experts who had done independent medical evaluations on the patient was to ask them, because they would always chart cranial nerves grossly intact. Now, do you all know the 12 cranial nerves? Can you describe each one and how to test it? I mean, some of you might be able to. Congratulations, most of your peers cannot. I know I've heard stories about how you learn about that in medical school and that it's forgotten shortly after you leave. Well, ChatGPT, flying colors, great. It can answer that question. But what about another few hypos? And I would suggest to you this is the reason why it's important. Judges instruct them, you can't use the internet, you can't use outside sources, you have to only pay attention to what's going on in the courtroom. We know that doesn't happen. They go out and look. So in medical liability cases of the future, what are they going to find? This is not for you to use in your clinical practice. Okay, so here's a case that we actually, well, let me just tell you this. I think jurors are already using ChatGPT. Okay, we know they're using social media to look at doctors. We know they're looking at your practice. They're looking at your reviews when you're in trial. And here's a case where we did lose a trial recently, but the damages award was not significant. That's why I picked this one out to show you. So I posed some questions to ChatGPT to see what it would say. So, is it a violation of the standard of care for an anesthesiologist to tear the patient's soft palate during intubation? And ChatGPT says, well, I'm not a medical professional, but I can give you some general information, and here it is. It equivocates. It may or may not represent a violation of the standard of care. All right, so then I get a little more aggressive, and I say, okay, well, what if the clinician used the glide scope and didn't directly visualize the endotracheal tube as it was being inserted? And ChatGPT said, well, potentially that could represent a violation of the standard of care. So now I get a little more argumentative, and I push a little harder. I said, but if the anesthesiologist didn't directly visualize the endotracheal tube, isn't that negligence? And ChatGPT said, well, potentially could represent negligence and a violation of the standard of care, but medical experts are really needed, good answer here, needed to determine whether the standard of care is violated. So I guess I can live with that in that scenario, okay? But what about wrong-sided surgery? So orthopedist, prepped should be having a right knee arthroscopy, and actually left one is is the one that's operated on. And that's going to be tough sledding, no doubt, right? And ChatGPT says, yep, operating on the wrong side is generally going to be understood to be a violation of the standard of care. I will say I know of at least one case that my former law partner tried and won a wrong-sided case. So, there's an asterisk around everything. What about a ductal injury during a lap chole? Is that a violation of the standard of care? A little more concerning here. ChatGPT says, yes, generally considered to be a deviation of the standard of care. Why is this concerning? We have won plenty of these cases. Okay, so ChatGPT isn't telling us what juries find here. And again, jurors are going to be looking there in the future. There's no equivocation this time. And then last example, again, we've won this case, 65-year-old male with an elevated PSA. And ask, is it a violation of the standard of care to prescribe a prolonged course of antibiotic therapy before proceeding with biopsy or referral to urologist for possible workup of prostate cancer? And ChatGPT, again, no equivocation, yep, violation of the standard of care. So in your practices, do you have folks who are thinking about using AI? Aside from ChatGPT, let's make clear, a takeaway here, you cannot use ChatGPT for clinical care for a variety of reasons. We've talked about that. But then you got to go through some fundamentals here, and I've been asked, do we advertise it? Probably not. You don't advertise that you're using it. That's my thought. Do you disclose it to the patient that you're using it? Maybe. It depends. We'd have to talk about that. Do you document it? You ask 3 different defense lawyers whether you should document your use of AI in practice, and you're going to get 5 different answers. Okay, so the jury's still out on that. My personal view is, yeah, you need to document it, particularly where you disagree with the algorithm. Do you roll out a retrospective review? In other words, do you dump data into the algorithm when you go live with it, historical data? My answer to you would be no on that. Do you blame it in the event of a bad outcome? You might try, but guess who's going to be arguing against you on that? The software company that sold you the AI. They're going to say, we can't do anything without the licensed clinician. So, you're looking at the wrong folks. And then do you do a demo of it before you go live with it, before you decide to use it? Absolutely. Okay. So you have to, again, tread carefully here. And there's one case out there that I'm aware of, and only one, where software was a co-defendant. This was in a New Jersey case where a patient died of a coronary artery occlusion after an unusual combination of drugs by Dr. Sotillo for weight loss. Husband sued the doc. The husband also sued the software company. Bottom line is the trial court excluded the testimony of the plaintiff's expert because he was not a software expert. And the appellate court overturned that and said, you don't have to be a software expert. We're talking about standard of care here. And again, the issues in that case were the software company against the doctor who prescribed it. Software company saying, we didn't prescribe it, he did. It's up to him for liability purposes. Last topic, cyber. Okay, we're actually going to make it. And I'm going to go through this pretty quickly as well. The world before ransomware. I actually think I was in this room 5 or 6 years ago presenting at this conference where we talked a little bit about social media and ransomware. And I do presentations all the time, all over the country. And 6 years ago, when I was presenting to folks about cyber, ransomware was something we were talking about. And it's quite remarkable how fast and how far we've come. In 2015, there were 60 ransomware reports noted worldwide, 60. And this is data from 2021, but it illustrates the trajectory we're on here, 600,000 in 2021. That's the growth in just those handful of years. Before ransomware, I would be presenting on things like this. What do we do when we have a fax that goes to the wrong place? Those were the questions around cybersecurity, and frankly, HIPAA is what we called it back then. Back then, just 5, 6 years ago, it was about compliance. The Office for Civil Rights in Washington, D.C. is a division within the Department of Health and Human Services, and it is the investigative and the enforcement arm for all things HIPAA, okay? That's really what we're talking about, is how do you avoid the ire of OCR when it comes to sending a fax to the wrong place or someone putting hard copy records into a dumpster, things like that. It was more about a paper world when we were talking about these issues. Today, it is about data as an asset and a risk. What does that mean? That means it's about keeping your doors open when you have a cyber event, okay? It's not so much the regulator concern. And these days, what I'm finding is cyber insurance applications are actually providing the current framework for how you shore up cybersecurity in your practices. It's not the information that OCR might be sharing, although they are increasingly sharing information, and I would compliment them for that. But there's also today some staggering headlines that can take your breath away, and there was one just within the last week. This was from last year. Hackers have the ability to control key infrastructure in the U.S. And what is one component of key infrastructure in the U.S.? Healthcare. Okay, and we'll talk a little bit more about that. The headline I read this past week was not only do they have the ability to control, but update, they've been doing it in some limited fashion for the last 5 years. Okay, pretty scary stuff if you sit around and think about it. The FBI published a report last year that, no surprise, confirms that, in fact, of all the different aspects of critical infrastructure, healthcare is the most frequently attacked. So more than manufacturing, more than government, more than schools, things you read about, healthcare is the target. And it's difficult to think that like global political events might impact hackers' interest in your practice, but it's been well documented that they can, and they do. There's a direct tie between the war in Ukraine and healthcare cybersecurity in the United States, fact. And I think that was, you think about health of elected officials, health of military leaders. Hackers and nation states want to know about that. Think about the Department of Defense Secretary being hospitalized. They want to know those kind of things. And case in point, about a year ago, information of members of Congress actually was exploited during an attack on a health insurer in Washington, D.C. So it's not just academic. And by the way, ChatGPT is playing a role in this stuff too. You've got sophisticated Russian cyber gangs who are attacking healthcare providers in the United States. And for them, English may not be their first language. Who can help with that? ChatGPT. So they're helping hackers now draft their phishing emails as clickbait for your employees and for you. So the game is not getting easier. And one of my favorite sources for updates on all things cyber is published by this law firm. And again, establishes no surprise, 23% of all cyber incidents involve healthcare. And they doubled down on attacking healthcare during COVID, by the way. You didn't get a break. They actually put it in full throttle because they knew you were vulnerable. It's sickening to acknowledge, but that's true. And if you think because you're in a relatively small practice or organization that you're going to be immune from the kind of things I'm talking about, you think again. 20% of all cyber incidents that were reported in the data most recently available involve practices with or entities with less than $10 million of revenue. Okay, 50%, 50 involve those with less than $100 million in revenue. So why? Because hackers are going after the weak gazelles. They know smaller entities have less expertise, less money to spend, and less staff, and less ability to stay afloat if in fact their laptops become bricks. Okay, so that's why they're targeting in a meaningful way, an intentional way. So my questions for you, hackers are in the system a long time before they're even discovered, and then they're in a long time before they're contained. Do you have an incident response plan? Like literally, like a paper copy of an incident response plan, because if your computer won't turn on, the one you've got saved, via your laptop is not going to help you. Okay. Do you have HR complete your cyber insurance application? Please don't do that. You need to have a subject matter expert within your practice who's paying attention to cyber stuff and can truthfully answer the questions on an application so that you don't get accused after an event of making a misrepresentation about the cybersecurity within your practice and therefore avoid coverage. And do you have downtime procedures? Does anybody know what downtime procedures are? That means when you can't use your computer, again, it's a brick. And what we're finding is that people who are relatively recent out of training, nurses, physicians, physician assistants, they don't know how to use paper charts. So, have you tested that? Have you simulated it in your practice? OCR still relevant, still rearing its head at the end of last year with some examples of enforcement actions against healthcare providers. And you can see the numbers. They're not extraordinarily large. Again, you need to pay attention to the regulators, but that's not your primary concern. Your primary concern here is keeping your lights on in the event of a threat actor taking control of your system. And so a couple things here. What is MFA? I think most of us probably know multi-factor authentication, right? If you take one thing out of what I'm telling you today, make sure that you've locked down all of your financial accounts, your personal financial accounts with MFA. That's just absolutely required, okay, and easy to do. That means you get a text to confirm it's you before you can transact financially. What else must you do? You need to have, I'm going to give you 5 things here when it comes to cybersecurity, and I'm not counting the MFA. You need to subscribe to OCR newsletters. Again, you've got to have that SME, subject matter expert in your office who's going to take charge of being abreast of developments when it comes to cybersecurity. And I've got the link to subscribe to that here, and other resources are available at OCR as well. Number 2, you need to have an external email warning for any inbound that comes into your practice. My hope is most of you have this already. If you don't, you need to institute it yesterday. That should raise the suspicion level when someone gets a suspicious email, because phishing is predominantly the mechanism that threat actors are using to infiltrate practices. Number 3, not an endorsement here, but you need to have a system that will help you triage, quarantine, et cetera, flag emails and allow your staff to report them. So if someone gets a suspicious email and they report it, then it can get pulled out of everybody else's email inbox. Okay, and I've provided a couple examples here. I'm sure there are others. You also need to regularly test employees and do mock phishing tests on them to help train them to recognize suspicious emails. Additionally, a lot of words here, don't worry about it. This legislation created a ransomware warning vulnerability pilot program, and CISA put out a fact sheet. And I know this sounds like a lot of stuff. Okay, this is why you're going to have your designated expert back at your practice, and he or she can look at these links and follow up on this. But essentially what's happening here is the feds are now trying to get proactive, and when they notice a vulnerability that might affect you, they're going to reach out to you. They're not going to wait for you to reach out to them. So if you get notification from someone with this RVWP, ostensibly from CISA, like that's why they're going to let you know. And there's been instances of them informing health systems of what I'm talking about here. So it's not a spoof, and you need to independently trust but verify. Is it CISA? They tell you how to figure out whether it is. But here's the 4th thing you need to do. Your practice should become familiar with the regional CISA cybersecurity advisor. Used to be my advice would be to meet with your local FBI agent, make sure they know who you are, you know who they are, so you can call them, because you're going to have that person's contact information in your paper copy of your incident response plan. Okay, now I'm actually shifting and saying I think you need to meet with your CISA cybersecurity advisor as well. Allows you to skip the formalities when you got a problem, and you are sitting in Region 4. And again, the links are in the slides here, so you can find them there. Number 5, as I've said now for the 3rd time, you need to have a subject matter expert in your practice who knows about this stuff and is keeping current and monitoring your vendors, et cetera. So do all of the above, and this isn't shameless self-promotion, but there are resources out there like the Back Table podcast. I don't know if any of you are familiar with that. It's an outstanding resource. They don't have GI clinical information that I'm aware of, but they've got a ton of other business-oriented podcasts. And if you want to learn more about this, here's a potential place to find it. Okay, so my multiple choice question for you, as we are actually, I'm sorry, I'm about a minute or 2 over time. Sorry, Bill. Okay, so here's the question. To treat my patients via telehealth when they are temporarily physically located in other states, you can read the answers. Anybody want to take a guess as to what is the correct answer? D. Good job. Thanks for listening. So 2 do's from today. Be an informed voter in state, appellate, judicial elections. Get advice on asset protection. Remember state lines when it comes to licensure. You have to be licensed where the patient is physically located in order to give care. Just because you have technology that makes it easy to do that doesn't mean it's okay. Figure out how to document the use of AI, and don't use ChatGPT for clinical care. And lastly, take your pick on all the things I talked about for cyber. Thank you for your attention. Enjoy the rest of the conference.
So Darshan, you have to follow that. So we get to hear about acute pancreatitis. It's a managing an old problem with refined tricks. Dr. Kathari is at Duke. He did his residency training at Beth Israel Deaconess and is going to update us on a very common problem. So welcome to the podium.
Good morning, everybody. Thank you to the North Carolina GI Society for inviting me here today. We have about 20 minutes to talk about a pretty common problem, so I look forward to the conversation we have during our panel discussion for any questions. I have no disclosures. So our learning objectives is to appreciate the burden of acute pancreatitis in the United States, discuss the evidence behind the mainstays of treatment, define pancreatic fluid collections, and review the management strategies, and then recognize quality indicators for patients admitted with acute pancreatitis. So why is acute pancreatitis an important problem? Well, it amounts to over 620,000 visits a year in the United States, and that amounts to about greater than 280,000 admissions, and this was updated recently in gastroenterology by our colleagues at UNC. And despite the fact that we have reduction in mortality and length of stay, it amounts to over $6 billion in patient charges. That is an insane amount of money that we're charging for this really important problem. And so I think it's important that we recognize how to treat this. Quickly, just to go over the diagnostic criteria needed to diagnose someone with acute pancreatitis, it requires 2 of the 3 following: epigastric pain, lipase that's greater than 3 times the upper limit of normal, and then having some form of acute pancreatitis on cross-sectional imaging. I put an asterisk there because if you have the first 2, you really don't need cross-sectional imaging, although oftentimes our emergency rooms are getting it anyway. The etiology, the most common in the United States, happens to still be biliary pancreatitis or gallstones, followed by alcoholic, but then there are other problems that I list here, including hypertriglyceridemia, ERCP-induced acute pancreatitis, along with a list of others, and that amounts to about 20% of all cases. And then the rest is sort of idiopathic acute pancreatitis. I have a quick slide here for drug-induced acute pancreatitis because this seems to come up a lot. And the reality is that it's actually a rare cause of acute pancreatitis. And the possible mechanisms are sort of listed here, whether it's an immunologic reaction like in 6-MP or direct toxic cause to the pancreas, or accumulation of toxic metabolites as in with valproic acid or tetracycline, ischemia, intravascular thrombosis, and if you all do what our trainees do in the hospital, they kind of go up to date. You sort of see all this list. I list this here because the reality is that the left side of the screen is what has the, quote, greatest data, but the reality is these are still all case reports with variable latency and reproducibility. So I would say, with caution, eliminate these drugs from a patient's list, but the reality is that these patients will oftentimes need these medications, and so I wouldn't necessarily take them off if it's something that's important to their other medical problems. So what happens to our patients with acute pancreatitis? What the majority of patients have what we call interstitial or bland pancreatitis. Because there's no evidence of organ failure, the majority of them resolve, and as a result, their mortality is quite low. A minority of patients will have what we call necrotizing pancreatitis, where there's actually cell death and damage to the pancreas. And with these patients, they'll have either some form of transient organ failure that results in moderately severe pancreatitis, but that usually resolves. But because of the transient organ failure, you'll see a mortality that's a little higher than that of mild acute pancreatitis. With persistent organ failure, these are the patients that we are oftentimes consulted on, and these are the patients that have persistent organ failure. Some of these patients will have sterile, the majority of these will actually have sterile necrosis, but some of these patients will actually have infected necrosis, and this is where sort of the mortality really is. And so the majority of these patients or the patients with infected necrosis are the ones that we have to worry about that have the highest mortality. When we think about early management of acute pancreatitis, I think about what are the types of IV fluids we want to give, what's the fluid rate we want to think about, how and when we should feed our patients, what kind of imaging is necessary for these types of patients, what kind of risk factor modification can we do, and then what do we do about these fluid collections? The reality is that there's so many guidelines that have been published on this, and in fact, in one year we had competing guidelines that actually said opposite things, and so it becomes quite muddy in times in reality on how we treat this. The most recent guidelines actually came out in 2018. by the AGA that sort of talked a little bit about the initial management of acute pancreatitis, and this is sort of what I'll go through right now. When we think about what we should be doing for patients that initially come in, we want to risk stratify them because that's going to help us understand where they need to go. And you can see here, it's again very clear which one we should be using. Not really, right? There's a whole list of them. The one that I think about that's probably the most friendly to use is something called the BICEP score. And the BICEP score is the bedside index for severe acute pancreatitis, and it includes these indices, so a BUN that's greater than 25, looking at the mental status, thinking about whether or not SIRS is present, age, and then pleural effusions. Important here, BICEP scores that are greater than 3 have a greater risk of mortality. So if these patients present with a BICEP score of greater than 3, you really need to be thinking about admitting patients with close clinical monitoring. And I think this is where, as consultants, we can actually be advising our ER physicians and our hospitalists about what we should be doing with these patients. These are the patients that we really want to think about. I get this question from trainees often: should we be trending lipase and does that help prognosticate? The reality is that trending lipase actually does nothing for the patient. If you have a patient whose lipase is getting better, but they're clinically doing worse, you're not going to change your management. But what we do see is patients who have elevated lipase lipases that are persistently elevated. Patients are oftentimes being denied diets. They're staying in the hospital longer. So I would argue against using lipase to prognosticate outcomes in acute pancreatitis. I put this slide up here really to demonstrate that there have been recent randomized controlled trials with regards to using balanced fluids versus normal saline. And the reality is that it seems that lactated ringers may be better in critically ill patients. These trials didn't isolate patients with acute pancreatitis, but the overwhelming data suggest that lactated ringers is better than normal saline in all comers. But why? It's thought that lactated ringers or buffered solutions reduce pancreatic acidosis. In trials that have looked at lactated ringers versus normal saline, there have been no great outcomes that have been demonstrated with hard outcomes, so on mortality or organ failure. There are, however, ongoing trials that are recruiting patients right now to answer this question. So in the current guidance, they say that lactated ringers is no different than normal saline, but I will say that the majority of us still believe that lactated ringers is probably better in patients who come in with acute pancreatitis. More important than the choice is actually the balance. We want to balance hypovolemia to prevent circulatory collapse or pancreatic microischemia, but we also want to prevent fluid overload and thinking about patients who have, and putting patients into respiratory failure or compartment syndrome. Hydration strategies in acute pancreatitis is important. We think about one strategy being sort of a set it and forget it model, where we just give patients a set of volume and just sort of come back to them and see how they're doing, versus weight-based bolusing and then thinking about goal-directed therapy. But the reality is that we really are trying to get this sort of sweet spot where we're looking at close monitoring using clinical parameters, including vitals, BUN, and hematocrit, and ultimately that improves outcomes. This trial came out last year and probably sets the tone of how we should be really thinking about fluid management in acute pancreatitis. And this was published in the New England Journal, and it was a randomized control trial where they randomized patients to goal-directed aggressive therapy, which included 20 cc's per kg bolus followed by 3 cc's per hour, versus moderate fluids, which was 10 cc's of bolus if they were hypervolemic, and if not, they just received 1.5 cc's per kg per hour. The primary outcome was development of moderate or severe acute pancreatitis, and the primary safety outcome was fluid overload. Important. The trial was actually stopped because there was a significant difference in the safety outcome. So the key takeaways here is that we need to be thinking about a more restrictive form of fluid management because we do not want to put patients into fluid overload. So start with 10 cc/kg bolus. If they're hypervolemic, maintain euvolemia, and actually encourage diuresis to support euvolemia in the first 72 hours. So when we think about patients with the type of fluid, I say here normal saline is equal to lactated ringers because frankly, fluid is fluid, so we don't want to prevent patients from getting fluid. There's emerging data that might suggest that lactated ringers may be better, but more to come on that. Maintain euvolemia is important. What about nutrition? So I think we used to say, should we be using the gut or not? I think it's very clear here we should be using the gut, and so we should be avoiding TPN. What should we do about when to start feeding? Well, it turns out that when we looked at this meta-analysis for early versus delayed feeding, there was no difference in complications when you fed them early, and so really you want to think about getting as early feeding as possible, but you can really wait up to 72 hours. Is post-pyloric feeding really necessary? Well, food is food in these patients, and so getting them some form of nutrition is important. And so it turns out that NG tube feeding is no different than NJ tube feeding or post-pyloric feeding. So why don't we just let them eat? Well, in patients who have acute pancreatitis, they have a lot of, they get early satiety, they have cachexins that are sort of upregulated, and as a result, they don't actually have that urge to eat, and so sometimes they just need that trickle feeds to actually allow them to get the calories that they need. This was a great algorithm that was published by Todd Barron and others in 2020. It kind of goes through the different, their sort of thought process on how to introduce feeding. I break it down a little differently, and I think about it as, okay, if a patient has acute pancreatitis, if they have mild or moderate, I go in and I ask them, are you hungry today? If they are, I start letting them eat oral feeding at 24 hours. If they're not tolerating it, I retry on day 2 and day 3. And if they're not eating by day 3, then I'll consider enteral feeding at 72 hours. For severe acute pancreatitis, I think the threshold to start enteral feeding is probably a little lower just because these patients are unlikely to want to eat up front. And so I really want to encourage you to start thinking about enteral feeding maybe even earlier in these patients with acute pancreatitis, and really thinking about TPN really in patients who can't tolerate adequate enteral feeding. Maybe they're vomiting, maybe they've got a bad ileus, or if their gut is compromised. So what happens on day 1? Patients, you walk into their room, they get clear liquids, and they've got this wonderful fat that's just sort of floating on top. It turns out that patients who actually get this type of diet up front actually lengthens their stay. So I would encourage you in your notes when you get consulted to really encourage patients to start a low-fat salad diet up front, because it reduces hospitalization rather than doing clear liquids. What if my patient has recurrent pain? I think we need to reset the expectation with our hospitalists. Our patients have a burn or a bomb that's gone off in their belly with acute pancreatitis, so they're gonna have pain. And so what I encourage our trainees at Duke to do is to really think about it as you want to encourage them to eat. If they have pain, you're gonna support them. It's when they're not able to eat because of nausea and vomiting, as that's when you probably wanna back off. So you really want to think about low-fat diet up front. So what kind of workup really needs to happen as an inpatient? You want to rule out gallstones. You want to do a thorough medication reconciliation and really consider substance abuse counseling, because as I mentioned, the second most common cause of acute pancreatitis is alcohol. I usually tell patients to at least check a set of LFTs, calcium and triglycerides, but I would avoid doing an MRI while they're in the hospital, as it's unlikely to change management up front. But you might want to consider this when they see you in the office. And if a patient has a very strong family history or are having recurrent acute pancreatitis, that's when I really consider genetic testing, but I really sort of rule out all of the other causes first up front. So what kind of imaging am I really talking about? Ultrasound is really helpful for patients with, to rule out cholelithiasis and to get a CBD measurement as a surrogate for choledocholithiasis. I think about CT in the first 7 days when we're trying to rule out an alternative life-threatening diagnosis, and later than 7 days when I'm trying to rule out necrosis. MRI, as I just mentioned, is probably better as an outpatient, but if you're worried about patients who are in that intermediate category for cholelithiasis, getting MRCP would be helpful. Sometimes we think about it with autoimmune pancreatitis, but I usually think about it in those patients who are greater than 40, getting it out just to rule out a space-occupying lesion, and particularly those patients we might be concerned about malignancy. For EUS, I really don't think about it in the acute setting, especially because it's not really gonna change our management unless there's a fluid collection, which we'll get to in a second. And I think about ERCP really only in those patients who we're concerned about with cholangitis. But the reality here is ultrasound is the thing we really want to think about for patients to rule out gallstones. So with risk modification, this is a kind of a great plot on thinking about what happens with patients who have acute pancreatitis, and you can sort of see the trend. You can sort of see the trend with patients who have biliary pancreatitis and alcohol actually being the highest, because usually where these patients are continuing to, or many times these patients are continuing to use alcohol or have some level of chronic pancreatitis, and as a result, they may have recurrences thereafter. I just want to highlight here that the biliary pancreatitis is so low because this is in sort of the time where we started thinking about getting the gallbladder out. But if we really thought about what it would look like before, you would see that the trend would be much higher for patients with biliary pancreatitis if we didn't get their gallbladder out. And in fact, this is sort of the Poncho trial that shows that in patients who have biliary pancreatitis, if we don't get their gallbladder out, their mortality or readmission for gallstone-related complications goes up significantly. And as a result, we really want to think about getting the gallbladder out during the index admission. When do I consider ERCP? As I mentioned, it's really only considered in those patients who we worry about have cholangitis. A plug here to really think about getting patients plugged in for some kind of substance abuse or social work when they're coming in with acute pancreatitis. And this was a randomized control trial that basically showed that patients who had an initial intervention had lower occurrences of acute pancreatitis thereafter. And so for these patients, you really want to think about ruling out gallstones and thinking about malignancy thereafter, getting the gallbladder out during the index admission, and thinking about alcohol counseling. Now, what about fluid collections? So this is just to review the nomenclature here. In sort of standard language, we thinking about acute peripancreatic fluid collections as those homogeneous fluid collections without any sort of solid components versus acute necrotic collection where there isn't a rind that's around the necrotic collection. If it's greater than four weeks, that's when we're really using the term pseudocyst and walled-off necrosis. When we're thinking about the indications for drainage, we really want to think about if there is infection in the pseudocyst or the necrosis. And we think about using antibiotics in those patients who really have radiographic evidence of infection, so there's gas, or if they're clinically appearing infected. There's no great data to suggest the use of empiric antibiotics for patients with necrosis where you don't believe that there's infection. And you can really get away with a fluoroquinolone. You don't have to really think about sort of imipenem or anything like that. You want to think about draining those patients who have ongoing organ failure despite optimal therapy. This is probably the most common reason we drain things, where patients present with sterile fluid collection but have persistent symptoms, and then patients who have a disconnected gland. And this is a good sort of schematic of what a disconnected gland looks like, where panel A is sort of a side branch that's blown out, and panel B looking at sort of a mid-gland necrosis where you have complete duct disruption in the body of the pancreas. When we think about pancreatic fluid drainage, the most common ways we think about doing it is sort of transmural drainage and transpapillary drainage. You can consider getting IR involved or surgery involved when you have sort of retrocolic or pelvic collections that are not accessible endoscopically, or if patients are before that 4-week component. But this is sort of really what we want to think about. And now in the advent of lumen-opposing metal stents, axiostents, this is probably the best way we can get about draining these fluid collections. But as a warning, these stents can cause erosion and bleeding, and so we really think about not keeping it longer than 4 weeks, and even shorter than that nowadays. This is another great scheme that I adapted from Todd Barron's work in gastroenterology from 2020 when we're thinking about the acute phase for patients with severe acute pancreatitis is really supportive, then getting them nutrition rather, and thinking about debridement, and then ultimately getting a multidisciplinary approach for those complex collections. So we only think about draining them if they're symptomatic, and you don't need to really think about prophylactic antibiotics. Only think about antibiotics in those patients who have infections. What about guidelines? So there have been multiple studies that have looked at how good are we at guidelines. So this was a study by DiMagno in 2014 that was published at Michigan, and where they actually paged all of the providers that came in with acute pancreatitis to sort of force them through an algorithm, and it actually looked at patients received better fluid up front and more appropriate triage to the ICU, and they had shorter length of stay. Similarly, I did a study at BI where we sort of try to manage patients in the emergency room with mild acute pancreatitis, and you could see in this sort of complicated scheme that we were able to actually discharge those patients who had the mildest form of acute pancreatitis. But in addition to that, we showed that there was a shorter length of stay. There was no difference in 30-day readmissions for those patients who were discharged, and we had a reduction in patient charges and healthcare utilization. These are the quality indicators that the ACG have put together for acute pancreatitis, but I want to just highlight three of the hospital-based quality indicators. And really, you want to think about cholecystectomy before discharge, early feeding, and avoidance of parenteral nutrition. So how does this actually work? So we actually looked at this at Duke, and we looked at a retrospective cohort of 309 patients with at all of our hospitals between 2019 and 2020, and you could see here that about 3/4 of the patients were getting fed in the first 24 hours, but of that, only 10% were getting a solid diet. So the remainder were getting all liquid diet. And only 2/3 were getting their gallbladder out. So what did we do about this? We actually we revamped our acute pancreatitis order set, and now it encourages in that order set getting a surgery consult. We've actually tried to revamp the communication strategy with surgeons to try to get the gallbladder out during that index admission. And actually, with these interventions, we have seen that there have been a greater uptick in solid diets as well as gallbladders coming out in that index hospitalization. So thank you for your attention today, and this is our CME question, and this is a 47-year-old female who presented to the emergency room with acute onset abdominal pain, nausea. She has a history of hypertension. She has a lipase of 4,000 and findings of acute pancreatitis. She only takes hydrochlorothiazide, and her social history is notable for tobacco use and 1 to 2 drinks per week. Her LFTs are normal when you see her, and our ultrasound shows gallstones rather. She receives IV fluids on hospital A1. She's feeling better. Her diet is advanced to low-fat solid diet. And before discharge, the team wants to know what they should do. So do we A, stop the hydrochlorothiazide? Do we consult social work for alcohol cessation? Do we consult surgery? Do we get an MRI? Do we send IgG for subclasses? C, great. So the most common cause of acute pancreatitis is gallstones, and with documented cholelithiasis, you should undergo cholecystectomy during the index admission. Thank you, everybody.
It's nice not having to put those tubes down past the pylorus, past the duct, isn't it? Our next speaker is a keynote speaker. This is Jason Samarasena. He's joined us from UC Irvine School of Medicine. And Jason is the chair of the ASGE Special Interest Group in Endohepatology. He's the director of the Advanced Endoscopic Imaging at UC Irvine, and we're going to learn about endohepatology. Welcome.
Well, hi everyone. Bill and Gresh, thank you so much for this kind invitation. It's a pleasure to talk on this topic, and happy to say we've had a lot of experience in this field called endohepatology. with my mentor coining the term back in 2012. Just waiting for the slides. So I got to give a little kind of brief piece of this talk yesterday at the Pentax house, and it was funny because it was a sponsored talk. Cook Medical was sponsoring the talk, and they had no idea what the venue would be like. So I came in my my suit, my tie, and my backpack, and was ready to hook up the laptop, and this was definitely one of the most fun talks I've ever given because essentially it felt like a college frat party that I had to interrupt to run through these slides as quickly as possible so the party could just continue. But we had a lot of fun last night, so thanks for that. All right. These are my disclosures. So there's been a growing number of endoscopic procedures that are pertinent to liver patients, particularly regarding endoscopic ultrasound. And we've termed this area of integration or overlap of endoscopic procedures within the practice of hepatology as endohepatology. And this was coined in 2012 by my mentor, Ken Chang. And so the integration of endoscopy within the practice of hepatology, and I think the tagline should be making the liver cool again. And so there's a few different things that we think about with endohepatology, and I'm going to talk about 4 things today. One is variceal interventions, EUS-guided liver biopsy, EUS-guided elastography, and then portal pressure gradient measurements. So we'll start off with EUS-guided interventions for variceal bleeding. So worldwide, the management of gastric variceal bleeding is usually sort of endoscopic, direct puncture into the varix, and injection of glue. And sometimes, that this works very well. We don't do a lot of training in this in the United States, but sometimes this can happen after you do that. Or if you start with this, it's very difficult to kind of manage that situation endoscopically. But with endoscopic ultrasound, even if there's a huge blood clot in the stomach, you can still visualize the varices. So you get better assessment of the size and morphology. You can use Doppler to evaluate flow, pre-intervention and post-intervention. It doesn't require any luminal visualization, and then you get potentially more accurate delivery of glue. Some of the disadvantages are that the glue could actually embolize, and you could have a systemic embolization event. So to kind of mitigate this, we kind of stole some tricks from the interventional radiologist, and now we use embolization coils. And these are used as kind of like a scaffold for the glue to reduce the risk of glue embolization systemically. And the coils are made of this soft platinum with the synthetic fibers to promote clot formation. For the endosonographers out there, the 0.018 coils are compatible with the 22-gauge needle, and the 0.035 are compatible with the 19-gauge needle. And essentially, you kind of get these coils from IR. You attach it to the inlet, and then essentially with the stylet of the EOS needle, kind of push them through. And you get them down the bore of the FNA needle. And when you are ready to kind of deploy these in the patient, essentially you're getting the stylet back in, and you're just using the stylet to kind of push that coil out of the end of the needle. So one of the largest and initial studies that looked at this was work done by Kenneth Binmoller and in San Francisco. 152 patients with gastric fundic varices. Most of them had some recent bleeding. 5 had active hemorrhage. And once EUS confirmed obliteration, the rate of post-treatment bleeding was only about 3% on follow-up. So I'll play this video so you can see some large varices. Here on EUS, you can see that you can measure the varices very easily. You puncture, And and then depending on how large the varix is, you can choose the type of coil in terms of diameter and length. In this case, it was a 20 millimeter coil that was used, followed by 2 cc's of cyanoacrylate glue. You can see that there's still some residual varix, and you can confirm that on Doppler as well. So you can repuncture. And then now an additional 15 millimeter coil was placed, and then an additional 2 cc's of glue. So after the coil and glue injection, that's what it looked like. And on 3-month follow-up, you can see complete obliteration. Now, one of the things that's a little bit of a problem for us as endosonographers is there isn't really a commercially available glue system, and so we end up sort of getting glue from kind of other sources and putting it in the needles and put it in syringes, and it's kind of messy. So one thing that's been tried is this absorbable gelatin sponge or Surgifoam. It's routinely used in surgery. It absorbs 45 times its weight of whole blood. It doesn't lead to any fibrosis or tissue reaction, and you can inject it as a slurry. So, our friend Marvin Yu has sort of figured this out. You basically cut up the Surgifoam, put it in a syringe, and use a 3-way stopcock. And with saline, you can just sort of mix it up, and it creates the slurry. And it's a really, really easy preparation to make compared to the glue. And so, so Marvin's done some work with this, and so similar kind of principle with embolization, but instead of the glue, you're using this gelatin sponge. And so here is a fluoroscopic image with some contrast showing a gastrorenal shunt that's kind of feeding that gastric varix. So there's some coils that have already been placed. Puncturing the varix again. And some more coils. You can see the coils there fluoroscopically. And then injection of the gelatin slurry. So kind of the take-homes for EUS-guided variceal interventions is EUS probably better assesses the size and morphology of the varices than EGD. You can use Doppler to evaluate flow pre and post-intervention. It doesn't require luminal visualization. The disadvantages are that systemic glue embolization risk. So Surgifoam may be better, and that's something new that we're studying right now. One of the, I would say, the biggest issues with this is there really isn't any standardized training for this procedure. So Marvin and I are working with the ASG to create some models where we can actually train people on this procedure. And it really does need the buy-in from interventional radiology. Depending on the your institution, interventional radiology may be very strong with coming when it comes to variceal interventions, and maybe there isn't as much of a need for kind of the interventional GI group to handle these cases. And so having a kind of a multidisciplinary approach with these patients always a good idea. All right, next topic, EUS-guided liver biopsy. So we all know liver biopsy plays a pivotal role in evaluating and directing the therapeutic management of patients with liver disease. Things have kind of moved in GI from kind of percutaneous biopsy. Now most of our biopsies are being done by interventional radiology. But there are some potential advantages for EUS. So it could be technically reproducible regardless of body habitus. So some obese patients with EUS, it really doesn't matter if they're obese or not. It's possibly less painful. The image guidance approach, because we're seeing exactly where the needle is going, you could potentially avoid blood vessels. And you also have access to a wide segment of the liver parenchyma, including the right and the left lobe. Now, if you look at the AASLD and other society guidelines on what the minimal measurement should be, really the AASLD is looking for a 2 centimeter length and greater than 11 complete portal tracts. So 2 centimeter length and 11 complete portal tracts. So how are we doing with EUS? So this is one of the first studies done by the group at Geisinger. It was 110 patients, and they used a 19-gauge straight FNA needle. They used 7 to 10 actuations. So actuations are when you kind of go in and out. And fanning is when you use the elevator and sort of tilt. And in this study, the mean aggregate length was 38 millimeters, so, and the median complete portal tracts was 14. So, you know, very, very good results, although other studies tried to replicate this and weren't able to with this needle. But there's been an evolution in the kind of needle technology, and now we have sort of this new kind of generation of needles that we're calling core needles, and the term now is being referred to as fine needle biopsy as opposed to fine needle aspiration. So this was one of the studies done, which was on a human cadaveric model, and they looked at some FNA needles, and they looked at 2 FNB needles, and they also looked at 18-gauge percutaneous needles. It was a very, very kind of big protocol. In addition to the different needles, they used a 1 versus 3 fanning passes. They used a dry needle with varying suction. So there was a lot of different variations in the way each needle was tested. So there was actually a total of 288 liver biopsy samples, so 48 per needle. And the results, 3 fanning passes seemed to be better than 1 pass. Dry suction, there was really no difference between slow pull, 20 milliliters suction, 10, 20, or 30 milliliters of suction. And in terms of the complete portal tracts, this 19-gauge shark core needle seemed to perform the best and was able to provide specimens that were the least fragmented. This question about suction has come up over and over again. Is dry suction okay, or is wet suction better, where you're actually lubricating the inside of the needle with some heparinized saline or saline? And so this was another study from the Geisinger group that looked at 40 patients. Each patient had 3 successive passes, each with a different type of suction technique. So 19-gauge FNA needle, 7 to 10 fanning actuations, and a 4-centimeter excursion. So they kept the protocol very tight. The first pass was the control, just dry. So the stylet was pulled out, and they just used 20 cc's of suction. The second pass was what's called a dry heparin, so a heparin flush, and then 20 cc's of suction. And the third pass was wet heparin, so they kept the heparinized saline in there, and then put the 20 cc's of suction on. And basically what came out of this was wet suction appeared to be the best technique for getting the largest specimen. This was another study looking at this fine needle biopsy needle, and this was an interesting study because it just did 1 pass, 1 actuation with wet suction, and as you can see here in this study, now the cores are getting much longer. Median total length was 60 millimeters. The median number of complete portal tracts was 18. 36 patients in this 165 patient cohort did have some abdominal pain, so this might be a new thing with these FNB needles, but overall a low rate of complications. So we took this a little bit step further, and we did a study looking at 2 different types of these new generation fine needle biopsy needles. This was a prospective repeated measure crossover study where we did a liver biopsy in 1 pass with a single actuation using the 2 FNB needles, and they were randomized to left and right lobe, and then also the needle sequence. And what we found, we did 44 liver biopsies in 22 patients, and the complete portal tract number was higher in the Francine tip needle as opposed to the fork tip needle, but regardless of which needle we used, and regardless of which lobe we used, the specimens really were adequate for making a diagnostic evaluation. So now, one of the things that we've realized is this kind of suction technique and how people are doing the suction really is important, and so we just had this accepted in Video GIE with a full manuscript to follow. And I think we finally figured out like the right way to do this. And we've been kind of messing with needles and messing with suction and doing all sorts of different things. But I really think that this is the best way to obtain the best liver biopsy with the US FNB. And so it's a pretty simple modification to this wet suction technique. And essentially, you actually start with the syringe off. So you then kind of do one throw, you put the syringe back on, and then you open and close. And that opening and closing will actually draw that liver specimen into the needle, and then you basically bring the needle back about 2 centimeters from the liver capsule. You open, throw, close, and then you do that one more time. So on the third pass, it's open, throw, close, and then you're done. And so to show you kind of this in action, this is Dr. Kenneth Chang. And so before he is doing his first throw, so we're still kind of in the stomach, gonna take off, throw, we're gonna put on the syringe, and we're going to open and then close. And so that's sort of pulling the specimen that we just got into the needle. And we're going to pull back to about 2 centimeters from the liver capsule. And for our second throw, we're going to open right before we throw, open, throw, close, and then we're going to bring back again, and then for our third, it's the same process as the second one. Open, throw, close. So what we found, this is the data we presented at DDW last year. So 31 patients over 12 months, technical success was 100%, no serious complications. But now the lengths are, our average fixed length was 6.74 centimeters. We had actually one specimen that was 16 centimeters long. The average complete pleural tracts now, our goal is 11, now we're hitting about 23. So we really feel like this is, by far the best technique that we've used, and I think this is probably the right way to go. So take home for EUS liver biopsy, it seems like core versus straight, the newest core needles appear to be superior to the straight needles. Pain appears to be a little bit more common with these new core needles, and technique matters. We realized that a single actuation may be enough, but 3 is likely better. Fanning method is helpful. Longer excursions lead to more tissue. Right liver may be better than left, and I have some data that kind of shows that. A heparin prime needle with wet suction is better than dry suction, and this new dynamic wet suction technique may be the best. So EUS guided liver biopsies are clearly exceeding the minimum AASLD requirements, and we need to start doing these sort of correctly as a group and getting the word out to our hepatologists. All right, the next topic is EUS-guided shear wave elastography. We've all heard of FibroScan or fibration-controlled transient elastography, and uses shear wave to estimate liver stiffness, and it's really a surrogate for hepatic fibrosis. The limitations are it has a low positive predictive value, and there's suboptimal performance in patients with morbid obesity, and really you're obtaining measurements really only over the right hepatic lobe. So EOS here may also potentially be a little bit better. We're getting a real-time visualization of the hepatic parenchyma when we do an EOS. The advantages are you can select maybe an optimal spot for measurement. It can be performed in patients with morbid obesity or patients with narrow intercostal spaces, and both the right and left lobe, as well as the spleen, can be assessed. So the latest EUS processors have this feature called shear wave, and essentially you get this sort of bounding box, and you kind of direct it to the spot in the liver where you want to take measurements, and you hit refresh, and basically you get these measurements in kilopascals. You can see on the rightmost column, and we usually take 10 measurements, and then we get this average that we record for that lobe, then we move to the next lobe, and then we move to the spleen. And so we did a study looking at bilobar, liver, and spleen shear wave and its association with hepatic fibrosis. So we were looking at different cutoffs for shear wave and predicting stage 3 fibrosis or better. And so we actually used the cutoffs that were already established based on the MR elastography literature, as well as the vibration FibroScan data as well. And when we looked at cutoffs, it looked like if you had a left lobe or right lobe measurement greater than 15 and a spleen measurement greater than 26.3, and if you had them all together, your sensitivity and specificity, positive, negative predictive value were the best. So more to come with this, but this is sort of a new module on the latest EOS processors. And one of the challenges right now is it is kind of operator dependent. So if your endosonographer is pushing it a little bit too much on the big wheel and you're kind of compressing the tissue, you can alter the results. So we're kind of working with a prospective protocol now where we can kind of standardize this. But the initial data is pretty promising. And the last section is probably the section I'm most excited about and we've done the most work in. It's EUS-guided portosystemic pressure gradient measurement. We know that portal hypertension often marks a transition to decompensation, and the hepatic venous pressure gradient, or the portosystemic pressure gradient, accurately reflects the degree of portal hypertension and is the single best prognostic factor in liver disease. The current standard measurement is an interventional radiologist going through the jugular vein, kind of going down and putting a catheter into the hepatic vein, getting a balloon-occluded measurement, which is an indirect measurement of the portal venous pressure, and then getting a free pressure of the hepatic vein. The advantages of this are it's kind of invasive, it uses radiation, and you get that indirect measurement of portal venous pressure, which will make the gradient inaccurate in certain types of portal hypertension. And so endosonographers have been trying to figure this out for a long time. Bill Brugge started this work in 2002 in a pig model. There was some bleeding complications, and Dr. Krancevoy again took a crack at this in 2008 in an animal model. And it wasn't until my boss, Ken Chang, and our team at UCI kind of took this on back in 2014, and I think we kind of figured it out. We created this novel EUS-guided pressure system using a 25-gauge needle and a compact manometer. And we did this in an animal model, and my buddy in interventional radiology, who I invited down, unbeknownst to him, we were kind of, scheming and, devising something that would probably take away business for him in the future. But he didn't know it at the time. He just hey, just put this catheter here, thanks. And so here what you can see is something kind of cool. So it's a fluoroscopic image of his balloon catheter in the right hepatic vein, and our echo endoscope putting a needle in the same vein at the exact same time. And on the right side is the EUS equivalent of what we're seeing there. And what we found was really exciting. It was like we were reading like the same pressures. And we used a dextran model, portal hypertensive model, and at various pressures, and we actually, and you don't see this, we actually did this in arteries as well in the pig, and the pressures were really, really tight with what we were getting with the balloon catheter and EUS. Let's see if we can play this video. Joanna, can you try and hit that video? Thanks. doesn't look like it's like in the video, but it's okay. You can kind of see the setup here in this, just the picture. And so it's a 25 gauge needle. There's some compressible tubing, and there's a manometer, and then you basically hook everything up, and doesn't look like it's working. It's okay. We'll go to the next one. So, the thing that we learned here was going through the liver parenchyma is definitely going to be the safest way to get these readings. In the early animal work, the others had kind of learned that just going directly into the portal vein does cause some bleeding. So all the punctures that we do is transgastric through the liver parenchyma into the vein. So this is you can see here going through the parenchyma into the vein and the hepatic vein, and the same thing with the portal venous pressure. Okay, so here you can see an actual case, and so the needle going through the parenchyma into this is the middle hepatic vein here, and you can kind of see the setup here. And we've got our fellow kind of holding the manometer at the mid-axillary line. We're going to flush with some heparinized saline, and then you can see the bubbles on the EUS, so that signifies that, yes, we're in the vessel, we're in the right place. And then what you can't really see on the manometer is that the numbers are going up really high, and then they're coming down, and then they're going to level out, and then we're going to record that level. And so what we're going to do here is a second push. You'll see the bubbles again, and then you're going to get a second reading, and then we'll do that a third time, and then we'll record all three readings and take an average. And this is now the portal vein puncture. So this is the left branch of the portal vein, and again you're going to flush. You'll see the little bubbles, fluid. And then the pressure reading is going to go up, it's going to come down, it's going to level out. So in this case, the portal venous median was 26, the hepatic venous mean was 12, and so the gradient in this patient was elevated at 14. So, what we learned was, when we had the fellow holding that syringe, we'd end up shouting at the fellow a lot because they would mess it up, and they would hold it too tight, and the pressure would go up, and so I think it was probably one of our fellows that invented this replacement, which is basically the stand, and it's like an IV pole, and we put it's like a little tray, and so we get a little bit of kind of double-sided tape and put it on there, and so now this has replaced the fellow in the room. And the fellows are much happier because it actually works really, really well. We actually have that red thing is actually like a laser level. So we put that on the tray, and then we kind of point it at the side of the patient, and we kind of line up the tray at the mid-axillary line, and then basically we're all set up and ready to go. So we've done this in human patients. So our next study was 28 subjects. They underwent EUS PPG, 100% technical success in identifying and accessing the target vessels. It's surprising, the vessels. I mean, we've been looking at the liver for years with EUS, and it's surprising how easy it is to see these vessels and access them. It's almost like they were meant to be accessed by EUS. And there was no complications in this initial study. And what we found was when we looked at subgroups of patients, the patients deemed more higher risk for cirrhosis based on imaging and lab information had higher mean portal pressure gradients compared to those that were deemed low risk. Patients who had varices had higher gradients compared to those without varices, and the same thing with portal hypertensive gastropathy. So there appeared to be some kind of correlation there. So we took this a little bit further, and we said, well, you know what? Maybe how does PPG compare to some of the sort of non-invasive markers of liver fibrosis. And this was a multi-center study. And happy to say that this was presented at the AASLD, and they didn't totally hate this. In fact, they gave it like a Best of DDW award. So I think the hepatologists are finally getting kind of excited about this and really kind of maybe believing in it a little bit more, or at least getting interested. So this was a study looking at EUS-PPG and clinical markers of portal hypertension, as well as the non-invasive markers of liver disease. And really, we're trying to figure out, there's a lot of patients who have sort of like equivocal clinical situations, like the FibroScan may show fibrosis, but like everything else doesn't really line up. And could PPG sort of sort out some of these cases? So things that we looked at were like APRI, FIB4, MELD, transient elastography, as well as liver biopsy. Technical success, this is over 300 patients, was very high with a very low adverse event rate. Again, what we found was great correlation with those clinical parameters that we looked at before: thrombocytopenia, presence of varices, presence of portal hypertensive gastropathy. And when we compared PPG with FIB4 and APRI, there was also very good correlation. We correlated with MELD, again, very good correlation. But interestingly, there was 39 patients who had concomitant PPG, FibroScan, and liver biopsy. 19 patients who had a PPG less than 5, accurately characterized patients with stage 0, 1, or 2 fibrosis, while the transient elastography was actually falsely positive. And so when you look at the PPG correlation with liver histology, it was really, really good. But when you looked at the PPG correlation with transient elastography, the liver histology correlation with transient elastography, it was wrong a lot of the time. And that was, somewhat concerning. There's since been another study that Garesh and his group has been involved with Dr. Harshit Kara, showing similar results that transient elastography, may not be so accurate for liver fibrosis. The other thing that came out of this, which was interesting, was there was 5 patients that had grade 3-4 histology, but if you look at their clinical information and their non-invasive markers, they were negative. So they didn't have any varices, they didn't have any PHG, they didn't have any thrombocytopenia, their APRI, FIB4, MELD score was low, the FibroScan was low, but in these cases, the PPG was elevated. And so it was only the portal pressure gradient that actually indicated that these patients had grade 3 or 4 histology. So again, sort of interesting, and it may mean that a PPG may be a little bit more sensitive and specific than some of the current non-invasive markers. So the take-home points for PPG, one of the unique things about it is it provides direct measurements of both hepatic and portal veins. HVPG is not accurate in pre-sinusoidal portal hypertension. That's one where an indirect measurement will underestimate the portal venous pressure. I didn't show this, but there's some data showing that in NASH cirrhosis, HVPG may underestimate the portal venous pressure, so the gradient may not be accurate in NASH cirrhotic patients. I think EUS-PPG is very easy to learn. You can be an endosonographer in practice for a year, and you can do this. The learning curve is probably like 4 or 5 cases. So it may be more accessible over time and repeatable than HVPG. And we talked about EUS-PPG being potentially more accurate than some of the current non-invasive markers. And there is a commercially available device, again, short learning curve, and there's formal training courses for this procedure. So I think the other thing is hepatologists are realizing now the endoscopist can really provide almost like a one-stop shop for endoscopic liver evaluation. So we can do the endoscopy, we can look for PHG, we can look for varices, we can do potential shear wave elastography to understand kind of the stiffness of the liver. We can do an US guided liver biopsy. Now we've got very, very good techniques for acquiring really, really great specimens. And now we can also do the PPG, which can be done very safely and easily. And with that, thank you very much.
Let me invite the speakers back to the podium, and we're gonna, Dr. Reagan from ECU Health is going to lead us in a panel discussion, and Charlie Strode from Asheville is going to join us. Unfortunately, Gerald Mank couldn't be with us today, but thank you very much.
The right. Okay, good morning, everybody. Sorry you can hear my voice is a little out, so I sound like a raspy man this morning. I didn't go to the Pentax party, by the way. But so welcome, panel. We've had some great discussion so far, and our panelists are no exception to that. As Dr. Leland said, Dr. Mank couldn't make it today, so Dr. Charles Strode from Digestive Health Partners in Asheville was able to join us. Thank you, thank you. All right, and this is our contact information in case anybody has any questions and would like to reach us. No disclosures. Okay, so our first case. This is the liver case. This is a 52-year-old male. He arrived to the ER by ambulance and he presented with altered mental status, jaundice, and couldn't give any history. No family can be found. And his vital signs, he's hypotensive and tachycardic. His hemoglobin was 5.5, BUN was 48. He had some elevated creatinine or acute kidney injury, and his LFTs were elevated. He would arouse to stimuli, but he couldn't answer questions. And his abdomen was soft, no grimace, and his liver edge was slightly palpable, some mild abdominal distension with some dullness to percussion in the lower abdomen. He did have some dark stool in his rectal exam and bed sheets. In the ER, they were able to stabilize him with emergent transfusion, and vital signs improved. He was started on medical therapy, including octreotide and PPI, and GI was consulted. So, Dr. Strode, what are you thinking here at this point?
Oh, I think your first, second, and third thoughts are this is a variceal bleed, and I mean you may have some other source of cirrhotic involved bleeding. You always have to keep your differential broad and think about ulcers and things like that. So. The PPI makes sense. I would probably, it doesn't say if he has ascites, but mild distension. So, you want to start your antibiotics too. You've given an appropriate transfusion at this point, and you want to stabilize the patient with plans to scope.
Great. So consent. So the first part of the case is going to be really related to informed consent. And it will direct some of this also at Jason Newton. So how are you going to get consent, or what are you thinking in this patient?
Well, if we've got no contact information and no family and no way of reaching anybody, at this point it's probably me and an anesthesiologist or an ER physician speaking with each other to get two physicians to sign on. This is clearly an emergent situation. And I think you could justify that, document it, and move forward from there.
So Jason, can you speak to that, I guess? What's our liability in this case, or what do we need to do to kind of protect ourselves in a situation like this?
Yeah, so I can't speak to the clinical details, obviously, but hearing what you said, generally speaking, if it's a life or death situation, then you do what you need to do, okay? But you do need to document. And what I would say is that you document that the patient's not able to give consent, that the emergency contact or the family member can't be reached, that you have an emergency and it's confirmed by another healthcare provider, which is what you've said, of the same status, in other words, another physician, the nature of the emergency, why it's an emergency, why delaying care is not an option in your view. And then if the patient is a ward of the state, that should be documented as well with attempts to get in touch with the responsible parties or family members. And really just underpinning that advice, I would say time and time again when we have experts who are reviewing cases on behalf of providers after a bad outcome, they can defend bad outcomes. Like the standard of care is not perfection, but what they can't defend is decisions where the thought process isn't documented. So as long as it turns, let's say you made the wrong decision here, you can still be defended, but you've got to document that thought process as well.
Great, thank you so much. Okay, so this is a picture from Dr. Samracina's slide set also. We made the decision to perform an EGD. The consent was obtained, and we found grade 2 esophageal varices and a gastric varix with a nipple sign. So Dr. Schroed, what are you thinking here in the community?
So in a community setting, I think one thing to keep in mind here is how stable is the patient, and are they actively bleeding at this moment? You know, if you look at the AGA clinical updates, which our friend Zach wrote, it would recommend actually with a high risk stigmata like that to go ahead with endoscopic therapy. I think in reality you have to judge what is my IR capabilities at my particular facility. We're blessed with good IR where I am. I would probably, in someone that's stable on octreotide and not actively bleeding, rather than intervene with a clip or a band, which is pretty much what I'm limited to. We don't have cyanoacrylate. I would probably call IR to consider whether or not there's a splenorenal shunt, and we can look at Berto or possibly embolization.
Great, great. Dr. Sammarcina, what do you think? When should we refer to an endohepatologist, or what tools can you add?
Yeah, you know, I think specifically with the management of gastric varices, it really does become about local expertise, and so sort of like what I had mentioned, you know, when we used to get a fair number of these patients, and we would be doing these sort of endoscopic interventions, and then we had a kind of multidisciplinary conference where we we presented our data, their endoscopic data, and the interventional radiologists presented their data, and quite frankly, they really kind of like outperformed us in terms of the amount of research that they're doing in this, their understanding of the shunt anatomy, how careful they are with kind of where they're occluding, with endoscopy. It's a little bit like, you know, we just do this sort of one thing and we just kind of hope it works, but they're a lot more thoughtful than we thought they were, and so so we've sort of now kind of almost like bowed out of the gastric variceal management, you know, at our institution, because you know, the two IR guys that are into this are really into it and very good at it. So I think it does depend on local expertise, but I know other colleagues who are at institutions where they feel, you know, very strongly about EUS guided, you know, variceal intervention, and you know, they're kind of the first line. So it kind of does depend.
Who would ban this? Who would ban this? Would anybody ban it?
Well, if it's actively bleeding, I think you have to consider how stable is the patient in an active setting. I think banding is not a great idea. Clipping is not a great idea, but if that's spurting blood at you while you're down there, I think that changes your calculus a lot.
Right, just stabilize the patient, yeah, or to get them somewhere, get them, if you don't have any of those resources, maybe even put a Blakemore in, that might stabilize that till you can get them where they need to go. Okay, so moving on, our bleeding was controlled, the patient was stabilized, and then some additional labs returned during their hospitalization. They've got a positive Hep C antibody and an RNA is pending. As usual, some of the autoimmune markers are a little bit mildly elevated, so a little confusing. And then an indeterminate ferritin in the setting of the recent transfusion. An alcohol level was negative, and tox screen was negative, a bilirubin of 4. Alkaline phosphatase was a bit elevated at 250 and a transaminitis. So labs were ultimately consistent with what appeared to be cirrhosis. So the CT with contrast was obtained. There was a little bit of mild hepatomegaly, but the liver was slightly nodular, you know, so this like disconcordant read that you get at times. And patent vasculature in portal vein with mild splenomegaly. There was moderate ascites, and a common bile duct was borderline at 6 millimeters with some possible mild intrahepatic ductal dilation. Right upper quadrant confirms this. And so, Dr. Sammarcina, what are you thinking now? What other tools would you have to offer in a case like this?
Yeah, so it sounds like this is sort of a new diagnosis of cirrhosis of sort of unclear etiology. So, you know, I think this person would potentially benefit from sort of that endohepatology workup, that sort of one-stop shop evaluation, but maybe not, you know, in the inpatient setting, potentially, you know, when things are kind of a little bit more stable, you know, coming back as an outpatient and getting things done. But I think, you know, this would be a referral to our kind of hepatologist for workup, and at our institution, our hepatologist would probably refer them back to us for an endohepatology workup, including EUS-guided liver biopsy, portal pressure measurements, you know, shear wave, and endoscopy.
I like that too in the setting of the AKI, the ultrasound can be helpful to look at the bile duct. So there's a lot of things that you can do, in this setting. All right. Thank you. So our next case, this is the pancreas case. So a 36-year-old female presented to the ER with abdominal pain for 24 hours, epigastric into the back and right shoulder, couldn't get comfortable, and some associated nausea. No prior episodes, 2 children ages 5 and 2, no real tobacco or alcohol, a daily multivitamin, and recently started a GLP-2. So it was afebrile, heart rate was 110, the vital signs otherwise normal, but a SAT was a little low at 93. On exam, there was a little dullness at the bases bilaterally and some moderate pain to palpation in the right upper quadrant epigastric region. White count was borderline at 10, hemoglobin was normal at 13.4, mild AKI with a creatinine of 1.3 and a BUN of 25. LFTs are elevated here with a bilirubin of 3, an alkaline phosphatase of 180, and mild hepatitis. Lipase was positive at 2,000. So a CT and ultrasound, both demonstrating the same, a CBD that was 7 millimeters, so somewhat dilated, and that tapers down to the distal CBD or ampullary area with no obvious stone. There was some sludge in the gallbladder, some mild fatty liver changes, and some diffuse peripancreatic edema and peripancreatic fluid collections. So Dr. Kathari, so what are the next steps in management and evaluation? What are you thinking?
So, I think the important piece here is to first risk stratify, right? So this patient has a BICEP score of 2 by virtue of the fact that her saturation is 93%. One could make an assumption that there may be a pleural effusion, and she might have some SIRS. So at most she has a BICEP score of 2, so still relatively low risk. So she probably could get admitted to the floor getting fluids, lactator ringers. I'm not getting a sense here that she's super dehydrated, though her heart rate's a little up, so you could probably give her a bolus followed by 1.5 cc's per kg per hour. And then, I think the workup for her cause, I think here we see here that she likely has gallstone pancreatitis, just given that she's got some sludge, and I would probably consult surgery to think about getting the gallbladder out on this admission. The incidental note of liraglutide or Mounjaro, I think is an important one because, there's been an increased use of these GLP-1 agonists, and with their increase, there's been concern for pancreatitis. I think the most common pancreatic insult is just an incidental elevated lipase without inflammatory findings. In this case, I probably would still have her get her gallbladder out because of the sludge that I've seen here, and then it would be reasonable to hold the liraglutide and then re-challenge her sort of as an outpatient.
Great, that's great. Dr. Sammartino, any other input that you might have?
I think in this case, in terms of next sort of imaging choice, CBD 7 millimeters, we get a lot of referrals for endoscopic ultrasound for these cases to look for the stone. MRCP obviously would be another choice here, but in a lot of cases, our MRCP backlog is quite long in our hospital. So sometimes it's a couple of days, and then so we'll get consulted and see if we can do an EUS.
Great. I know you had mentioned a new drug, maybe. A new drug. Mm-hmm.
Oh yeah. So I was going to ask Darsha about this. So I'm a PI on the site PI for a study called the CARPO trial, looking at a drug called Exora. And Exora is a crack channel inhibitor, and it's been used in COVID patients to decrease inflammation. And so now this is a phase 2b study looking at kind of dose finding for acute pancreatitis. And it's a pretty cool study because, as you know, pancreatitis is so terrible, and being an interventionalist, I caused pancreatitis, with the ERCPs, and so this is a drug that potentially could be kind of, I think, the first drug for pancreatitis treatment, and so that's why I was excited about kind of getting getting involved with this study. And we've enrolled a few patients, and they've all gotten better. And so exciting stuff. Hopefully, this will come to market, and we'll actually have, a medication for acute pancreatitis. So yeah, thanks for
That's
reminding me.
great. Thank you so much. Okay. So, hospital course, our patient improved with bowel rest and analgesia. We did get an MRCP that showed choledocholithiasis and a filling defect in the CBD with some gallbladder sludge. An ERCP was performed with sphincterotomy and stone extraction after the patient was stabilized and the initial pain improved. And a cholecystectomy was done 10 days after admission. 4 weeks later, however, she returned to the ER. She complained of persistent epigastric fullness, discomfort, early satiety. Her vitals were stable. On abdominal exam, she had moderate discomfort and palpation in the upper abdomen. Labs were pretty normal, and a CT abdomen and pelvis was obtained. So we see this. Dr. Kathari, what is this? What are we thinking?
So, looking at the cross-sectional image here, you see that there is a fluid collection that is in the anterior abdomen. It's measuring, I'm guessing, somewhere between 10 and 12 centimeters. It looks like there's a sort of rind around the loculated fluid collection, suggestive of a pseudocyst, and it looks like it's pushing potentially on the stomach.
So what interventions might we have? What are we thinking? Are we considering, or are we considering anything?
Yeah, so I think getting our advanced endoscopy pancreatic biliary providers involved here is important to drain this fluid endoscopically, given that it's probably accessible through the stomach. You can put a lumen-opposing metal stent to drain the fluid internally rather than putting an external drain. I think we need to be careful with using external drains, only because they can develop a fistula and things like that. So in this case, probably the best course would be to engage advanced endoscopy.
Dr. Schroed, anything in the community, I guess, that you would approach differently with this?
No, in this patient that's symptomatic, I think doing LAMS is totally appropriate here, as long as you've got a cyst that's over 5 centimeters in size. You don't have anything in between the gastric wall and the cyst wall, and you're within a centimeter of where your stent needs to go. Because you remember, you're working with a short stent. I've got to say, I don't know if I've seen a more game-changing thing come along since when I started training to when I'm practicing than how we do pseudocyst management now. It used to be an hour and a half of sheer terror trying to do cyst gastrostomy, and now it's done in 5 minutes. And I think the one downside to that, though, I would caution, is that just because a cyst is there and it's easy to get to doesn't necessarily mean we need to do something about it. You need to select these patients still based off of, are they symptomatic because of this? Are they infected? Is this something that needs to be cleared out versus something that I can just do?
Great. Dr. Sammartino, anything else you'd add?
Yeah, I think Dr. Schroed's right. It can be a 5-minute procedure, but we've seen some really terrible complications from these procedures as well. Now, I think any kind of interventional endoscopy trainee is learning these, and the deployment is very, very simple. But I think because of that, sometimes people are tending to put maybe these in inappropriately. I think, it really has to be a solid indication, which is essentially, and the indication shouldn't be pain. It should be, basically, difficulty with oral nutrition because of this. Darsh brought up a great point about how long we leave these stents in. These stents really should come out before 4 weeks. We found a lot more complications, the longer we've left these stents in, and part of it comes from the design. The edge of the stent is actually quite sharp, and you can almost get sort of almost like a paper cut type of effect with the edge of the coating. And so some of us are actually putting double pigtails within the lambs to serve as a bit of a bumper. So when that collection does finally collapse, and those vessels kind of in that rind are getting closer and closer to the stent edge, the double pigtail will serve as a little bit of a bumper. And so typically our process is, we'll place the lambs. I'll place one double pigtail within the lambs as well. And then at about the 4-week mark, we'll pull the lambs and just leave the double pigtail in there, which can really stay in there for the long term, and serve to kind of keep that tract open for kind of extended healing. That's basically been our practice. But before, we were putting in these probably too often, just because it was easy, and it's an extremely fun procedure to do, which is never good for
Like popping the zit,
Yeah.
kind of.
interventional
It's like,
endoscopists. You don't want it to be fun, otherwise they'll just be doing it all day long. Yeah.
Great. Okay. All right. So next, the legal case. What's your liability? So you receive a page from the ER after hours. Your patient is in North Carolina. You're in North Carolina. It's a patient that's not associated with your practice. This is a common call we all get and our fellows get. It's a 58-year-old with low-level rectal bleeding. They're stable with no prior history of colonoscopy. Their hemoglobin is 13.5. They want to let the patient go home, of course, and follow up with GI as an outpatient, but they want to know what your input is. What are you going to do? So, Dr. Strode, what would you advise in this case when they call you?
I mean, the first thing I say in this is that it's the clinical judgment of the physician there in the ER whether or not the patient's safe to go home. I think once you take that call and you start dispensing any kind of advice, you better be documenting what it is and then have a plan of how, if you're saying that you're going to follow up, you better have a plan of how you're going to follow up, both data probably in documentation and then implementing the next morning if this is, 7 o'clock at night. And then hope that you have some good follow through. And the other thing too would be sure that you have some good contact information for the patient on top of all of that. This is obviously a sticky situation I think we all deal with, and I think Jason would be the most helpful here.
No,
Jason?
I think very well said, and I would just maybe add some color around that. I live in an ivory tower, and I tell you, document everything. And if you documented everything I told you, then you wouldn't have time to practice. But I think also you need to make sure that the team that's calling you has an understanding of the limitations of what you'll do, what you won't do, and what you'll document. The last thing you want to happen is to have sort of a duel in documentation. And be, the plaintiff's lawyer would be trying to use you against each other after a bad outcome. The other thing I would just caution you to understand is that I still find today a lot of physicians don't know what an audit trail is, and that's a forensic record, a digital record of everything that happened, everything you looked at, the things that you did not look at, and so on and so forth. And so keep that in mind too.
Great. Thank you guys so much. I think we'll have to stop there for the sake of time, but thank you guys so much. Great panel.
Thank you to our panelists. If anybody has any pancreatic or legal questions, our panelists might slip outside there and you can catch them as we're going to move to the final module. Our final module is on the endoscopies, and our first speaker is Dr. Pawa from Wake, and she is going to join us on the podium. You may have been seeing some of the advertisements. She has written the most recent guidelines on how to not have any musculoskeletal injuries from our procedures. And so let's look forward to her talk.
Good morning, everyone. Can you hear me okay? Okay, let me just see if I can get started here. Hi, my name is Dr. Swati Pawa. I'm a therapeutic endoscopist at Wake. I also am the chief of GI at the Salisbury VA. And I'm very thankful to the organizers and Dr. Girish Mishra for inviting me for this talk today and for all of you to be present for this talk. So my title's a little offbeat, and it talks about ergonomic endoscopy and why it matters. So I'm going to try to see if I can move forward. Okay, I think I've got it now. These are my relevant disclosures. And I'm going to divide my talk into 3 categories. The first one, I'm going to talk about the scope of the problem, which is to understand the prevalence of endoscopic-related injury. I'm going to follow it with the problem of the endoscope, and we're going to talk about the biomechanical risk factors for repetitive strain injury during endoscopy. And then finally, how do we apply our knowledge of ergonomics to the endoscopy suite? So let's talk about the scope of the problem. The demand of for GI endoscopy is increasing, and it's going to further increase because we've lowered our screening for colorectal cancer to 45 years. So we're going to have more screening colonoscopies, more colonoscopies for post-polyp surveillance. We have now newer technologies like AI, where we have increased adenoma detection rate, which is also going to lead to more endoscopy. And there is increasing utilization of cases that were traditionally managed by surgery with advanced endoscopy. So overall, the endoscopy is going to continue to rise, and our user mix is changing a little bit. 51% of active GIs are now greater than 55 years of age, and increasing women in GI, which we've never seen before. So I'm going to take a step back and walk you through the history of endoscopic-related injury. This is not new. There's been a gamut of literature, almost always survey-based, because that's the only thing we could do. And the first study was maybe back in 1994. I can't see very well what I wrote over there, but it was by Bushbacher. He went ahead and surveyed 269 endoscopists, all at the ASGE, and found that half of them were complaining of ERI. Fast forward to the last decade, and we've seen a slew of papers that have come out talking about ERI, and it's ranged anywhere between 39% and 89%, I think. So let me talk about why endoscopy is contributing to injury. So we're going to talk about a paper by Hansel, which was a case-controlled study at Mayo of GI physicians and compared GI physicians to non-procedural internal medicine specialties and found that the rate of musculoskeletal injury was higher in the GI group. So GIs do endoscopy. And then came some key papers, starting with the ASG paper in 2015, which surveyed 684 practicing gastroenterologists and found that half of them had experienced ERI. And some of the risk factors which were associated with injury included more than 20 cases per week, more than 16 hours of procedures per week, years performing endoscopy, and 55% of these folks required intervention, be it in the form of physical therapy, NSAID use, taking a break from endoscopy, changing their schedule, having surgery, or disability, which probably was the worst outcome. In 2017, AGA came up with their paper, which kind of remains in abstract form, but gives important information. They surveyed 826 practicing endoscopists. Women and men both had same risk of injury, but women complained of more injury in the upper extremity and the upper back. Risk factors, and we're kind of painting a picture here, which is repeating itself, but risk factors included more procedure volume, age, and prior injury, and only 4.5% of these surveyed participants said that they had training in ergonomics. Then in 2021 came the paper from the ACG, which I was involved in, and this is the largest study to date, about 1,700 practicing gastroenterologists or endoscopists, and 75% of them reported ERI. This is the short we're using for endoscopic-related injury. 90% reported more than one injury, 20% took time off for injury, 12% required surgery. Risk factors included years performing endoscopy. The more experienced you are, the more chances that you're going to develop ERI, and hours per week performing endoscopy. And we did a little better here. 61.5% reported no training in ergonomics. And this is a graphical abstract of the ACG study. And if you look at it, you look at the 1,700 respondents here, 583 were females, both men and women reported almost equal incidence of injury, but you start seeing a pattern. You start seeing that women report different areas of ERI than men and different mechanisms of ERI than men. So women had more upper extremity, upper back injuries. Men had more elbow and lower back injuries. And women reported the mechanism of ERI to be non-adjustable monitor, non-adjustable bed, and torquing with the right hand, whereas men reported more of using the elevator of the duodenoscope, lead aprons. And women reported that 79% of them had pregnancy-related ERI. So a very dismal picture, but again, painting a picture that ERI is common. And the more you are in practice, the more you're going to likely get an endoscopic-related injury. So the societies took heed, and this was a systematic review and meta-analysis published last year by the American Society of Gastrointestinal Endoscopies SOP committee, the Standards of Practice Committee, of which I was involved, fortunately, in these guidelines as well. We did a very thorough systematic review and looked at all the studies to date. We picked 17 survey studies, about 5,000 respondents. Overall rate of ERI was 57%. Most common sites of ERI were hand and fingers, back and neck. And then we took survey studies that had both men and women reported in them. Remember, the initial survey studies were predominantly just male participants. So as women increased in GI, we had 8 survey studies, about 3,300 respondents. And again, ERI in female endoscopists was about 62% versus 45% in males, and that did reach statistical significance. What does that mean? That means female endoscopists are at higher odds of developing ERIs. So what are work-related musculoskeletal disorders? They arise from a complex interaction of events that accumulate over time. So injury results from this accumulated effect of transient external loads that in isolation are insufficient to exceed internal tolerance of tissues. But let's say you're doing these repetitively, you're doing these long exposures, then they can actually, the internal tolerance of the tissues can eventually be exceeded, resulting in pain and disability. And again, these are 3 phases. So the early phase, you might just have pain while you're doing endoscopy, but when you go home, everything's okay. And then you have the second phase in the middle where you do have pain during endoscopy, and it sets a little bit early during your procedures. And then when you go home, the pain persists, but then it goes away. And you have maybe slightly reduced capacity to work. And then the late phase where the pain persists the whole day, and also when it doesn't let you sleep and you're not able to perform lighter duties. So listen to the pain. Pain is telling you something. So keep that in mind. So what are the GI-specific risk factors? So this is a previous fellow of ours who kindly enough agreed to share this picture, struggling with an endoscopy with us. You can see the awkward, non-neutral position that she's in right now as she's doing this procedure, the repetitive motions, the long hours of standing, the sustained static load for these procedures, and high forces that we exhibit are all biomechanical risk factors for injury. And just to give you an example, the small hand, the large dials, more force for the same movement, bad scopes, not moving correctly, again, more force for that's where the force is being generated as well. And then obviously, most of us who do ERCPs, or those of us who do ERCPs, there's also the static load of the lead apron. So some of the endoscopy-related adverse events can be in your upper extremities and shoulder. Again, biomechanics is the way you're handling the scope, and also the static load of holding the scope. And again, back in the neck, the shoulder, and the back, it can be your monitor position. This is not an ergonomic monitor. You can see the way I'm looking at it. It should be right in front of me. So your monitor position, your monitor height, your bed height, and again, the static load of the lead apron, and then pain in the legs, the prolonged standing, which can also then lead to endoscopic-related injury. So does hand size matter? And there's been a lot of debate about that, and so I'll walk you through that kind of step by step. But the first study came out by Cohen in 2008, and they studied GI fellows, and the GI fellows' perception, it was a perception study, they felt that hand size affected their endoscopic learning. Our study in 2021 with the ACG did not show any difference in the rate of endoscopic-related injury between hand size, but it did show that most women had small, extra small to medium gloves, so they had smaller hands. Then came a study by Miller in 2022, which is from Mayo Clinic, and they measured procedural and anthropometric factors which are associated with ERI, and found that small-handed endoscopists had longer colonoscope insertion times. And finally, this study, last year, so it came out in 2022, they took 50 medical students, novices to endoscopy, and measured their dexterity. And they noticed that the students, and they divided, so half male, half female, and they noticed that the medical students with smaller hands had more dexterity. They could complete the task quickly. Then they gave them a small dial bronchoscope and had them do some maneuvers, and then they measured dexterity, and they noticed that both the large hands and the small hands did equal. But then they gave them the larger-handed endoscope, and they noticed that the smaller hands fatigued more and were taking longer to do the same task. So the dial size matters, hand size matters. Smaller hands are requiring more force to be applied for that same motion, which can then lead to injury, especially in the upper extremity. So let's talk about the problem of the endoscope. This is where we're going to now lead into. So as you all know, the first prototype endoscope was a fiber optic endoscope by Basil Hershowitz. He was at the University of Michigan. He was a fellow over there. He did a journal club on fiber optics and then decided he was going to make this first scope. And it was, he did the first endoscopy on himself. It was looking at the patient with an eyepiece, had a camera at the end, and then an inflatable device. And fast forward to the 1980s, there's a revolution. The video endoscopes become available. You suddenly can see, you don't have to kind of go to the eyepiece. You can now see it all on the screen, and the optics are now getting better and better. But what hasn't changed? The human endoscope interface has not changed at all. So it's one-size-fits-all device for a one-sized workforce. That's the problem with the endoscope. So what is ergonomics? Ergonomics is a scientific study of how work affects people physically and cognitively. So more importantly, it's the science of fitting a job to the worker instead of vice versa, and understanding the limitations of that worker. So it's very important as we proceed to think about what can mitigate injury to kind of understand these two concepts. So the first one is anthropometry, optimized fit. And what does that mean? That basically means, your monitor should be able to be moved in our world. Our bed should be adjustable. We should be able to change positions. That would be more about optimizing fit. And biomechanics, minimize forces. So can we stand in a neutral position? Can we get that dial size to be smaller? That would be more biomechanics, is the minimizing the forces that are generated during endoscopy. So anthropometry is the study of human dimensions. So simply put, you design tools that can accommodate the 5th percentile female all the way to that 95 percentile male, and everybody in between. So it recognizes that there's a breadth of users, and if you make a device, you make it such that it satisfies all, as you can see in the picture over here. Biomechanics is how the body produces forces and generates movement. Muscle force, as if you remember back to your medical school days, is the interlacing between the actin and the myosin filaments. And when they are interlaced the most is that neutral position. If you deviate from that neutral body position, which you're going to hear a lot of today, that's when you are minimizing that maximum position of safety and that maximum force position, which is that neutral body position. And then it talks about sheer muscle mass, and in this case, female endoscopists are at a disadvantage from their male counterparts. So gender and age is the most important predictor of strength. Women in their strongest, and you're looking at their 20s and 30s, are equally as strong as men between 70 and 80 years old. So that's where, now you can imagine where we're going with this. So what is the importance of a neutral posture? So if you were to just stand in front of a mirror and close your eyes and kind of just get comfortable, that would be your neutral posture. So neutral posture is the resting position of each joint, so the mid-range of motion of any joint. So it is the resting position of each joint with the least tension on nerves, tendons, and muscles. And if you can see the pictures over here, it is the most mechanically advantageous position. And in this case, you can see the non-neutral postures. There's more effort that's required for that same effect. In this case, they are in flexion or they're in extension. And you can see the grip strength being decreased in both these maneuvers as opposed to a neutral position. So neutral body position would be if you're standing comfortably, you're standing on both feet, you have equal weight distribution, shoulder width apart, and you have the natural curves of your back and your neck. And these are some of the joints that you can see that I have. where you can see that the neutral position is right mid-range of motion, not extension or flexion. Imagine if your table height is up, your shoulders are automatically going to abduct. So you don't want that abduction or adduction. You just want the neutral position of the shoulder. And similarly with the back, if your bed's too low, you're going to be flexing a little bit like that to get to that same patient. And you want that patient at the edge of the bed as well so that you're not kind of reaching over. So think about your neutral position when you're performing endoscopy. And think how difficult it is for the wrist to hold a large dial, especially with smaller hands in that neutral position. You automatically are going to try to twist to get that motion or that high force. So those are all your risk factors that you're looking at. So good ergonomics is good economics. This is a deboning knife. These workers were complaining of disability over and over again. They were holding the knife in extension, as you can see, and they were having trouble with carpal tunnel syndrome. Now, get a pistol-shaped knife, and you can see how the wrist is in a nice neutral position, and the rate of injury has really gone down. So that is what we are talking about with the scope as well. So this was an article by Amandeep Shergill, who's done some seminal work in ergonomics and was the first to let us all know that there is a problem. This comes from her group. They measured forces that were exerted during colonoscopy and found, and this is there's a threshold value that's set by the American Society of Industrial Hygienists, so to speak, and these are the threshold values. That above these threshold values, you're going to have injury, and they noticed that there was high risk in the distal upper extremity in the left arm, and again, high risk in the right arm. So more forces were being generated in the right wrist, something that we're seeing a lot in the females endoscopists as well. So it's traditionally been seen that male endoscopists will normally scope and steer with the dials. They'll use both the big dial and the small dial, but the female endoscopists often will steer not just, they'll steer with their dials, but mostly with right torquing because they just can't get their hands on those larger dials as well. And that could then kind of make sense as to why the injuries, upper extremity injuries, are more common in women as opposed to men. So what do we do about it? So in ergonomics, we call something called the hierarchy of controls. What can we do? So at the top of this pyramid is elimination and substitution. Here we need that buy-in from industry, that buy-in that they're going to produce intuitive scopes, which are going to work for that 5th percentile female all the way to that 95th percentile male. But until we have that buy-in and those thoughtful scopes, we're then moving down that pyramid and we can do something called engineering controls. Again, you need to change your work environment a little bit. The engineering controls will require that you get caps if you have any, or if you have dial extenders, which can then help these hands to reach the dials better. If you have stands available, which are not available in the US, I know there's a stand trialing in Europe, but it's not still available, and we don't know if that endoscopic stand is going to help or not, but it is something that's in the works. Moving on from engineering controls, you can then go to administrative controls. Here you need buy-in from your directors, your director of endoscopy, your chief. You need buy-in there that they're committed to safety and environment of safety. You need buy-in from the techs, from the nurses, so that the scopes are furbished. They're not tight to handle, that they're taken care of, get their maintenance regularly, so to speak. You need buy-in for breaks. Can you have a hard break? Can you take a break from endoscopy? How's your schedule set up? Are you doing endoscopy every day? Can you take a break and not do endoscopy every day? Or can you take a break and stop midday and then do? So all of those things you're going to have to negotiate. And then it is us. What can we do? Well, we can take micro breaks, which we can talk about. We can stay healthy, stay fit, exercise, and we can try to, wear insoles, comfortable clothing, comfortable shoes, things that we can do to help ourselves through this, through this kind of practice. So let's talk about engineering controls. Now, there's a big push in Canada, or if you've gone to these train the trainer session, where they talk about optimal technique of holding the scope, and they swear by that C loop, where you can lay the scope on the bed in the form of a C and use your larger joints as opposed to your smaller joints to actually maneuver the torques and the turns required in a colonoscopy. You can get dial extenders. Now, Olympus, unfortunately, discontinued their dial extender. We just came to know about it as we were working on our manuscript. When asked, we really didn't have an answer. They said they were coming out with better scopes. we'll take that for face value. But eBay is full of these. You can actually order them at eBay. Some of these are not a one-time thing, so you can kind of reuse them. But the female endoscopists swear by them, and they feel like for their small hands, it really can help. I personally have not used these extenders. Ergonomic education. Now, this is big. You want that behavioral shift. It's very important. You get busy with your lives. You forget. You've got so many scopes to complete. Your schedule's all set. But you need to change that. And you need to kind of have that shift that I need to be cognizant of this and I need to behave or look after myself in that manner. But there are several studies out there. You could use a physical therapist. And at Duke, I think there is a physical therapist that goes twice a year, goes through the fellows, sees how they scope, tells them, watches them, and then gives them feedback on how they scope. You could have ergonomics coach, again, a little bit on the expensive side, this kind of help. Then you have educational sessions, teaching conferences such as these, online courses, and I'll refer to some online materials that are out there at the end of my talk. And then you can have posters hanging in the endoscopy unit, just something that makes you aware that this is the way we should do things. Micro breaks. So what are micro breaks? Micro breaks are short, biologically meaningful breaks lasting about 30 seconds to 2 minutes. So put down your scope just a little bit, for 30 seconds even, or just shake your hands if it's a longer procedure, just so that you break that static load. You just give your muscles, ligaments, tendons a little bit of rest. Now, for us who do EGD and colons, the procedures are not that long, right? So we might not want to take a micro break in the middle of the procedure. We're 15 minutes, 20 minutes. But in between procedures on a very long day, maybe between those 10 or 15 scopes that we're going to complete that day, we can take a break and just stretch ourselves a little bit, right? Now, let's say for those of us who do interventional endoscopies or those of us who do third space endoscopies, these are longer procedures going almost 2 hours, sometimes 3 hours. In those cases, taking micro breaks while you're doing the case might be more beneficial. So again, suit yourself depending on what you're doing. Targeted stretching micro breaks comes from surgery. This is mostly from surgical literature, where these are, again, small breaks, about maybe 1.5 minute breaks, where 20 to 40 minute intervals, which were targeting the neck, the shoulder, back, wrists, hands, knees, and ankles of these surgeons that you can see in the picture over there. So they were doing their surgery, then they would have this break, they would just do these exercises and kind of take a break and then come back to these long surgeries that they were doing. And then macro breaks are hard breaks. It's a hard stop. So it's something like, okay, I'm going to break for lunch. I'm going to have a 30-minute or a 45-minute lunch in between my day. That would require administrative buy-in for you to get that kind of a break. So these were the studies that came out of micro breaks, and the study that we did with the ACG showed that there was lower likelihood of injury when you took those breaks. So it didn't matter if you took a micro break or a macro break or you stretched. Anything, just a break, made your incidence of ERI lower. And then there's literature from the surgical side where it showed that the stretching micro breaks improved post-procedure pain scores in all the surgeons. Surgeons perceived improvements in physical performance, mental focus, and most surgeons wanted to incorporate these in their practice. So I'm going to spend the last 2 or 3 minutes talking about a work that I'm very proud of and was extremely lucky to be involved in. This was the ASG guidelines that, for the first time, a society took it upon itself to actually give some guidelines, finally, to this growing pain, so to speak, of endoscopic-related injury. We were a group of 14, 15 people in the Standard of Practice Committee. It was led by Bashar Kamseya, who was our chair at the time. We had content experts in the committee as well, and it was a very challenging and daunting task. You know, how do you give guidelines from evidence-based guidelines from literature that's not randomized controlled trials, but survey-based studies? We still took it upon ourselves because I thought we owed it to all of us to actually get these guidelines out. And we did a very robust review of literature, and we actually used the GRADE methodology to come up with these guidelines. So I'm just going to go over these as I end my talk. So the first guideline was that the ASG, and so where ASGE says recommend, it means it strongly makes that recommendation that you do it. Where we say suggest, that is a conditional recommendation because the data, even though it was weak, in some instances we thought we could still do a strong recommendation, in others we couldn't. So the first one was we do recommend ergonomic education, and we leave it to the user right now because we don't know what the best way of ergonomic education is. It's a new area, the data is scarce. So there are videos that are available at the ASGE website, the GI Leap. Amandeep Shergill has a video. Dr. Raju has an excellent resource on YouTube. He has several YouTube videos talking about correct positioning and all of that. There is GIE, in video GIE, there are series by Dr. Chang. Patrick Young is another ACG and therapeutic endoscopist, I'm sorry, who's published with the ACG with his video. So there are resources that you can go to, and they're freely available for you to use. Just in terms of how best to avoid ERI, what's the best position, how do you use ergonomics to your advantage. The second guideline was, the second recommendation, which again was a strong recommendation, was monitor position. You want the monitor not like this, but in front of you so that your eye can look at the top of the monitor or just a little bit below it, which can reduce neck injury and other upper extremity injuries. So you wanted the monitor at eye height or a little below, and you should be able to move the monitor. So if the monitor is on a boom, that's probably the best way to do it. If it's on a wall, you want to make sure that it's adjustable. But this is probably the one big thing that many endoscopy centers are struggling with, is that the monitors are fixed and are not able to move, and most of the endoscopists are idly, scoping in this position, which then causes a lot of strain on the neck, especially if they're short-statured. The third guideline was bed position. You always want the bed position to be at your elbow or maybe 10 centimeters below your elbow so you can rest it comfortably. You don't want to be stooping or you don't want to be abducting your shoulders when you're doing endoscopies. The ASG then made some conditional recommendations for this guideline, and the first one was micro breaks. So it told you to take micro breaks or macro breaks if you could get those in between procedures, and also use mats. And I know that this is a sore point with some centers because it's a tripping hazard. So if you can use a mat, remember, prolonged standing can cause you to have back pain, can cause discomfort, fatigue. So if you can get a mat, a cushion mat, that kind of gives you that uneven surface so you can actually shift your load and kind of move that lactic acid that's building up a little bit away. If you can do that, that's great. If your center says, no, we can't get mats because it's a tripping hazard, then you could get insoles, you can get comfortable shoes. All of that's going to play a role. You can get stockings because of the venous pooling. You can get compression stockings as well, whoever, to suit yourself to get yourself comfortable. I didn't put a slide in here, but I do want to say it. This was an afterthought, and I thought I should have, is disability insurance, especially with our fellows. The fellow data suggests that there is almost, there are only 4 studies that are out there for fellows, but the last study that was with us suggested almost half the fellows complaining of ERI. Now, this could very well be because they're learning how to scope, and they don't know how to scope well enough, but the risk of injury is real. And they are reporting this in their first, second, third year of fellowship. So getting disability insurance is not a bad idea. Explore your options. This is the best time to get that insurance, whether it's for short-term, long-term, there are riders associated with it. Is it for this occupation? Because you're an endoscopist primarily, not just seeing patients. So this would be the best time to actually go ahead and get disability insurance. That would be my one advice to the fellows as well, and to all of you as well, to get disability insurance. Finally, I would encourage you all to incorporate an ergonomic checklist. You can suit it to your advantage, but you want to get your monitor. So just, when you do a timeout before the procedure, as you're standing there, you just say, okay, now I'm just going to do a quick ergonomic timeout. I do it for my cases. I want to make sure the monitor is fine. I want to make sure the cushion's there. We do have cushion mats at Wake. I want to make sure that's over there. I get the monitor in the right position. I make sure the scope's right behind me and I'm not stretching. There's no loop in my scope or in the umbilical cord. I want to make sure that the dials are working freely. I will return a scope if the dials are tight because I know that I'm going to be exerting a lot of force in that long procedure that I'm getting into. I wear 2, when I'm wearing lead aprons, because I do ERCPs, I make sure that they are 2-piece. It's not a 1-piece lead apron. So all of those checklists, you want to make sure the pedal's near you and you're not kind of reaching out for the pedal with your thing, and you want to make sure, things you can add. team effort. So you can tell your team, hey, if you see me in a really contorted procedure or kind of a posture, you can correct me. So those are some of the things you can do as a group, and try to reduce the risk of ERI. So in summary and in conclusion, ERI can be debilitating. Modifiable and non-modifiable factors can contribute to these overuse injuries. Most effective measures to prevent ERI are industry and organization-led, and prioritizing ergonomics and incorporating the new ASGE recommendations may help prevent ERI and disability. Do we do that question, or do I keep moving? We do that question. Okay, so what have you learned? Optimal bed height while performing endoscopy is at elbow height or 10 centimeters below elbow height, at elbow height only, or at elbow height to 10 centimeter above elbow height, or 10 centimeters above elbow height. And again, like we've discussed, the correct answer is 10 centimeters below or at elbow height. If it's too low, you're flexing your trunk, straining the paraspinal muscles. If it's too high, abduction of the arms, and again, injury because of a non-neutral posture. I thank you for your attention.
Thank you. That was very good.
Thank you.
Thank you, Dr. Paula. That was very practical and very informative, and I know that a lot of us have had these injuries. Our next speaker is Jason Conway. He is at Wake, went to UNC med school and did his fellowship there, and he's going to be talking to us about unique uses for endoscopic mucosal ablative therapy beyond Barrett's.
Hello, and thank you. Thanks for having me. I was given a rather unique topic here to talk about endoscopic mucosal ablative therapies, which I use a lot, mostly for Barrett's esophagus. But for many of these, for many of us that do these, we've discovered other uses for these therapies, and that's what I'm going to talk about today. Here are my disclosures. I want to talk a little bit about just the technology, explain how they work, what these devices look like for many of you, those of you who may not be as familiar with them. And then, you know, this is a talk where there's not a lot of data. It's a little bit sort of show and tell, which I'm not all that used to, but we'll talk about the data or the diseases that we probably use these devices for mostly outside of Barrett's, including gastric antrovascular ectasia or GAVE, radiation proctitis. And finally, I'll talk a little bit about how we might be able to use these devices to alleviate patients that complain of globus. So what is radiofrequency technology? It's used really throughout medicine. It's heat energy, and it's heat energy delivered very quickly in a very precise, highly controlled manner using a bipolar electrode array, electrodes that are spaced very close together. So it is a very reproducible ablation. Here is a cross-section of esophagus. Up at the very top is the mucosa, and you'll see the depth of the halo system, or the RFA system, is about 5,000 to 1,000 microns. So when we use this system, we're ablating the epithelium and into the lamina propria, but not through the muscularis propria. Specifically, we're not getting into the submucosa. Because we're not exerting any tissue damage into the submucosa, you're avoiding a lot of complications, specifically strictures and things like that. The depth of injury is precise and reproducible. This is actually pig esophagus. On the left is normal esophagus. And after RFA, you can see that the epithelium down to the muscularis mucosa has essentially been completely stripped off, leaving the submucosa and the muscularis propria completely unaffected. There are many devices, and of course these manufacturers over time have come up with a variety of different devices. There are balloons, the Halo 360, which is actually a beside the scope device that goes over a wire that can ablate circumferentially. I use a lot of the paddle-like devices, which are attached to the end of the scope with a silicone cap. These devices are paddle-like devices that you can use to push up against the mucosa and ablate tissue very effectively. There's the channel device there on the left. That's a flexible, the the transducer there is very flexible, and it will actually go bend and go through the working channel of the scope, kind of pop out at the end. And it's extremely useful when you're working outside of the esophagus, specifically if you're in the rectum or in the stomach doing some of these interventions I'll talk about. This device is rotatable, so you can basically do a 360-degree ablation without having to torque the device extensively, say if you're working in the antrum. What about endoscopic cryotherapy? This is a relatively new thing. It's the application of extreme cold to tissue. It results in the rapid freezing of tissue. It leads to cell lysis and necrosis. It's a very different mechanism of tissue destruction than is RFA. RFA is heat energy. You're basically destroying and singeing everything from the cells to the extracellular matrix to everything. Here, the extracellular matrix is relatively preserved. Cells are frozen and lysed. That's the mechanism of destruction. The depth of injury here can also be regulated by the duration of cryogen exposure. So the longer you spray the cryogen onto the tissue, the deeper tissue injury you're going to get. And you'll see there's some situations where that may actually be of benefit to us, where, again, with RFA, the heat energy is relatively fixed, so that depth of tissue destruction is a little bit more fixed. This is the C2 Therapeutics cryoballoon focal ablation system made by Pentax. It's a self-contained contact balloon system. It uses liquid nitrous oxide. It's really easy to use. It basically is a balloon, almost like a short dilating balloon. It's about 3 centimeters in length. It's on a catheter. It goes down through a therapeutic scope, comes out the end of the therapeutic scope, and you blow it up. It's a very low pressure balloon. It's about 4 psi, so extremely low pressure. It essentially just distends the mucosa here in the esophagus. And you basically pull the balloon back towards the scope, and you look into the balloon, and you can see perfectly, just like you see there on the right. Within the balloon is a nozzle system, and that little white thing on the end of the black thing coming through the balloon is a nozzle that can be rotated and moved up and down throughout the balloon. That's where the cryogen is sprayed. That's where the liquid nitrous oxide is sprayed. You basically line up with whatever you want to ablate, say a patch of Barrett's. There's a foot pedal that you use, and that will spray the liquid nitrous oxide onto the tissue and cause freezing for a set period of time. You can change on a system how long you expose the tissue, and this system varies anywhere from 8 seconds, which is commonly what we use for flat Barrett's, all the way up to 14 seconds, which sometimes we use in the stomach. Again, a relatively easy to use system. The nice thing about this system is it's completely self-contained. So the liquid nitrous oxide is vented out of the balloon through the catheter into the atmosphere of the room. So you don't have to, unlike spray cryotherapy, where you have to use venting NG tubes essentially, here you don't. Everything is vented within the balloon. Nothing actually goes into the patient. The balloon freezes essentially. Whatever the balloon touches, that's what freezes. So let's talk a little bit more about the disease states that we use these in. So GAVE accounts for about 4% of upper GI bleeding. It's a relatively rare cause. Currently, most of us, I would say, use ablative therapies, specifically endoscopic therapy, thermal therapies, non-contact endoscopic thermal therapies like APC. It's pretty commonly available, I think, for most of us. Most, including the fellows, have probably used this. It's great. It's very effective. It's very easy to use. The problem with GAVE, especially in patients that have severe GAVE, it affects typically the entire antrum. It's not just a few little spots here and there. It's the entire antrum. And you're trying to treat a diffuse mucosal disease essentially with a little spot welder. And that can become very tedious, very time-consuming, and essentially you're getting relatively poor therapy to what needs to be effective therapy to a wider area. So unfortunately, despite endoscopic treatment, about 2/3 of these patients require ongoing transfusions. And this has really become a really big, growing part of my practice for sure, for my colleagues who will encounter GAVE, they'll try APC, but sure enough, the patient continues to require transfusions, continuing to bleed. They'll send them to me, hey, is there anything else that we can do? There are some data for this. There's a review of 10 small case series with about 72 total patients. about 73 or 74% achieved a complete clinical response, which was defined as the mean hemoglobin increase or independent from transfusion at 6 months. Minor adverse events at about 4.2, usually some minor bleeding, maybe some bacteremia. Usually about 2 to 4 RFA treatments were used every 4 to 8 weeks, and this is typically the treatment protocol that we use at Wake Forest. This is an endoscopic picture of how we do this and how we can essentially treat the entire antrum. So A on the far left is severe GAVE involving pretty much the entire antrum. A device, one of the paddle devices is attached to the end of the scope here. This is the HALA, the 90 Ultra. And this device was maneuvered essentially around and the scope torqued and the device repositioned so that the entire antrum could be treated. So you see on C, the entire antrum has essentially been treated with RFA. This, while it looks like it may be extremely tedious with some of the devices we have, takes 10, maybe 15 minutes, and you can essentially treat the entire antrum. And we're usually pretty aggressive in these patients. Again, this is a diffuse mucosal disease, and we treat it that way. So we're usually very aggressive and try to treat the bulk of the antrum. What about cryotherapy for the treatment of GAVE? There is a retrospective review of about 23 patients that underwent the cryoballoon therapy, the device I just described, for refractory GAVE. Again, about 83% of these patients were transfusion independent at 6 months. So again, we're kind of seeing this 75 to 80% improvement. No adverse events. Luckily, cryotherapy is extremely safe. About 70% of the patients had 2 treatments, 30% just 1 treatment. I'll say in my experience, it's usually 2 to 3 treatments is what these patients require, about every 4 to 8 weeks. Again, being very aggressive, even with cryotherapy, to treat the entire antrum. Here's a picture here of how this works. Essentially, what we do is blow the balloon up and kind of impact it into the antrum right at the pylorus. Try to collapse the antrum around the balloon and then spray within the balloon circumferentially to treat and freeze the entire antrum. I usually use pretty long cryogen exposure times in the stomach, 14 seconds, and work to effectively, in one setting, treat the bulk of the antrum, hence the bulk of the disease. And C is the antrum after most of the GAVE has been eradicated. What about radiation proctitis? It is a common problem, unfortunately, and it can affect about 20% of patients who undergone pelvic radiation. We see a lot of this in our prostate cancer patients. It can lead to chronic bleeding. In severe cases, it can lead to transfusion dependency. Again, non-contact thermal therapies, specifically APC, has been considered the first line of therapy. But again, we're treating a diffuse mucosal disease with essentially a spot welder, which can be, again, tedious and very time-consuming. APC also, especially in this disease, has the risk of treating certain areas potentially too deeply and other areas potentially not deep enough, which is the wonderful thing about endoscopic mucosal ablative therapies. They're specifically designed to treat very superficially in a very reproducible way. So APC has been considered. Complications of APC, though, have been severe. If any of you have had these, they're very difficult to deal with. Ulceration, perforation, strictures, fistulas, can be very, very challenging to deal with. There are some data, of course, for this. A review of the literature, about 6 studies, 71 patients. Most of these patients had radiation proctitis refractory to APC. Again, we're seeing these 75 to 85% after RFA treatment. A lot of these patients are transfusion dependent in 6 months. 1 adverse event, bleeding, requiring a clip placement. That was actually during the treatment. And essentially, these patients are getting 1 to 2 treatment sessions. Again, very safe, very effective, and really can help these patients become transfusion dependent, which can really be life-altering for many of these patients. What about globus? So this was thrust upon me, I think, a couple years ago by one of my colleagues who said, hey, I've got a young patient with globus. He has a large gastric inlet patch. Why don't you ablate it? And I said, what are you talking about? So I had to do some reading myself, and sure enough, we all see cervical inlet patches when we do endoscopy. They're so common, we often don't even comment on them. I certainly often forget to comment on them. These patches can actually be very active and produce acid. Some are believed to cause symptoms, including globus, chronic sore throat, postnasal drip, cough, excessive throat clearing, again, symptoms that many of us see pretty frequently. There are some data showing that APC ablation may improve some of these symptoms. There are some data for RFA in this patient population. Small study here in 2016, 10 patients with inlet patches and globus or sore throat. They underwent RFA, maximum of 2 ablation sessions, about 3 months apart, similar to what we do for Barrett's. About 80% of those patients achieved a complete histologic response. And again, that's very consistent with what you see in Barrett's esophagus as well. Symptoms of globus, sore throat, and cough scores were all significantly improved from baseline and persisted until about 1 year. I have done this in 2 patients. One patient symptomatically improved, the other was lost to follow-up. Surprisingly enough, insurance paid for both cases, which was really, really very surprising to me. So I think it's potentially an option out there for some of your patients. It's certainly very safe, and if you have the right patient with a large gastric inlet, it's something to think about. So endoscopic mucosal ablative therapies are very safe. They were specifically designed to be extremely safe. We've got some small case series showing that they may be effective in treating GAVE. They're effective in treating radiation proctitis, potentially even globus. Of course, we need more studies. Here's my question, which everybody should easily get. In which disease states has endoscopic mucosal therapies have been used? And GAVE, radiation proctitis, globus, of course, that's what we've been talking about. Yeah, I know.
I was like, what do you mean? I know. How many people skip right over globus? Maybe we need to learn some things. Okay, we're here ready for the panel discussion. If Dr. Chauhan would come, he'll be leading us. He's one of our board members, works for Atrium Charlotte. Joe Henderson is joining us. He is in Fayetteville Gastroenterology, and Dr. Paula.
All right. Thank you, everyone, for sticking around for this very last session. And I'd like to thank Bill for giving me the opportunity to moderate the very last session. But great talks by both speakers. I'm very intrigued by the talk that both of you all gave, but I'd like to start with Dr. Pawa. Maybe I'd like to poll the audience. I mean, this endoscopic-related injury is something that, perhaps I didn't really think about much, but I'm curious if I'd like to poll the audience, how many of the endoscopists in the audience have dealt with ERI in their practices? Okay. Are there any certain aspects that you have incorporated in your practices to reduce ERI or prevent ERI? Matt, anybody else? Or proper shoes? Surgery.
Oh, gosh. Yeah, that's a good point. Either you want to do how precisely do you grip, and the washcloth kind of is the better grip as opposed to just kind of you exert more force on your joints, small joints, if you're going to do a point grip. Yeah, good point.
Thank you. I had a question for you. You mentioned being more aware of the posture and all these things. For those of us that work perhaps in training programs that have fellows, should we be, or does Wake do anything in training our fellows? Like, are there any formal lectures that we should be giving to our fellows, more so than obviously observing them do endoscopy and maybe giving them some pointers on how they're standing, how they're holding their scopes? And I'm just curious as to what your experience has been.
Yeah, I don't think Wake has a program for the fellows. There is a body of work by Dr. Catherine Walsh and her colleagues from the training committee and the ASGE, which talked about a core curriculum for the fellows, which was published maybe a year or two, maybe 2021 or 2022, and talked about what you could do, pre-procedure, intra-procedure, and post-procedure. So that would be a good resource as well. The new guidelines are obviously a great resource for every endoscopist, fellow, or otherwise. We don't know yet what our best mode of education is, but and the fellows are with me, I definitely go over the steps. With them, I don't know if every faculty is, but I would strongly encourage everybody to do so, especially if you're in a training program and you've got fellows who are already struggling with trying to get the correct technique. I think this would be the best stage to let them know so that they are growing with that and it's a learned behavior. For us who have been scoping forever, it's a very, it's a paradigm shift and it's very difficult to change. And so even though, just to give you an example, even though we keep talking about, we keep harping, the endoscopers, Pentax, to their credit, actually did have a department for ergonomics, and they came up with several prototypes, but they were all rejected by the physicians or the endoscopists because we're so used to scoping a certain way. So there is this thing that if we start early, which is, like you mentioned, the fellows, that would be a good way to go. And so even if it's posters in your endoscopy unit, or the fellows might say, hey, I want you to focus on my ergonomic technique today. Because, we as attendings get busy in the day, we've got cases lined up, and the fellows themselves can come up and say, hey, this is what I want to focus for today. Can you comment on my technique? And that would be another way to give them feedback. There are programs as well with the ASGE, Endo Hangouts, and other fellow activities which talk about that as well.
Yeah. Thank you. Dan, thanks for that beautiful paper you wrote. I have one other question.
Well, it was a group effort.
Group effort. Two more questions.
Yeah.
You mentioned the dial extenders.
Yeah.
And that's certainly one aspect that might help. But I was actually thinking I've been using the disposable ERCP scope.
Very good point.
Which obviously the design of that was not for ergonomics.
Yes.
The purpose was obviously to reduce infection. But then I did a couple of ERCPs and I found it to be very light.
Yes.
And it got me thinking. I'm like, I wonder if, like you were saying, industry solutions, could we potentially, or industry, develop disposable endoscopes that are not one size fit all? And I'm curious to see what you think about that.
Absolutely. You hit the nail on the head. This is something that Boston Scientific and others who are in this territory are actually strongly thinking about. That could this be the answer? It might not be the end all be all, but at least it's a step in the right direction. Where they're lighter scopes, they are lighter scopes and smaller dials. I think those are the two big ones. Yeah.
And one last comment about this topic. One of our gastroenterologists in our practice does all his colonoscopies while sitting down, and it was interesting. I tried a few of those myself sitting down, and I found it to be more relaxing. The one issue that I ran into was the monitor.
Exactly.
So I'm sitting down, but I'm having to strain my neck. So although I felt more relaxed, but then my neck was more strained at the end of the day. So I'm wondering if you've tried that or anybody else has any experience with doing endoscopic procedures while sitting down.
So I developed sciatica, and my sciatica, because it comes in all shapes and sizes, mine about 2 hours into standing was incredibly painful. And near the point I would have had emergency surgery, but I learned to scope sitting down. And I was able to delay my surgery for a year.
Wow.
And I got to the point where I was less tired at the end of the day, and I swore that after my surgery, I would keep doing it, but I didn't. Because you're right there. It's not that nice.
You were wearing a mask? Were you wearing a mask?
I don't even wear gloves.
One glove, maybe? All right, thank you.
Yeah.
Moving on. In the interest of time, I have a couple of cases. Hopefully I can get through both of these. I'll skip through the first case because I know we're running behind and I'm the last thing that's holding you between leaving and maybe watching the Super Bowl this evening. But I have a case here, a 67-year-old gentleman who, with Barrett's, with high-grade dysplasia from outside biopsies, was referred to me for ablation therapy. So this was in a few years ago now, September of 2019. there is endoscopy. I did not see any, actually, sorry. The outside endoscopist did not mention any nodules, no focal lesion. He had fairly minimal past medical history, hypertension, hyperlipidemia. So I see him in October of 2019, and he did not have any visible lesion. He did have Barrett's, C2, M4 Barrett's, which I ablated with a paddle type catheter. I had him come back a couple of months later. He had C0, M1 then, which I again ablated. He came back. Then after that, actually, the COVID pandemic hit, so you see that big gap between December 19, and then he finally came back in July of 20. He had an irregular Z line. He still had an island of Barrett's that I treated. So now after that, he comes back about 6 months after that. And what I saw was what I looked like to me in that bottom picture, just an irregular Z line. I decided not to ablate. I said, let me just take some biopsies. I took some random biopsies. I didn't really, maybe my mistake, I did not do any targeted biopsies and label them. And the biopsies came back as at least intramucosal cancer arising in Barrett's. And again, there was no focal lesion that I could see. And my question to Dr. Conway is, what would you do at this point?
Yeah, frustrating, isn't it? We do these ablations, and they're so effective. And you get to this point, which is really the end point, where your Z-line is at the top of the gastric folds, and do biopsies, and you get something like this back. It's not uncommon for this to happen. This is, why the post-ablation endoscopic surveillance is so critical in these patients, because RFA is fantastic. We can eradicate Barrett's, we know, in about 80-85% of patients, but it's not 100%. And some of these patients can actually go on to develop esophageal adenocarcinoma. So that endoscopic surveillance, like you did, is just so critical. The next thing I'd say is, when we do endoscopies, it is oftentimes, our eyes are oftentimes drawn to very subtle abnormalities at the GE junction that we biopsy, and we may not even comment on them on our reports, but sometimes while we say there's no nodule or focal lesion, it's not uncommon for me to have this scenario, to say, gosh, go back and look at my pictures and say, I really didn't see anything. But oftentimes when I bring the patients back, sometimes there is something there. Sometimes there are even just small raised erythematous areas that perhaps I just overlooked as being normal the first time. That's where I think you have to have a very low threshold for EMR. So any kind of mucosal abnormality in these patients needs to be addressed, not with ablation, but with endoscopic resection. And I think most of us in those situations use a band-assisted mucosectomy device, which are very safe and very effective ways to remove some of these very subtle abnormalities. However, if you go back and you truly don't see any abnormality there, then you have to do something else. You have to do some sort of additional endoscopic mucosal ablative therapy. This isn't the kind of patient that I would refer yet onto surgery because they don't have an obvious mass. It's a patient that, if I go back and look and there truly is no lesion, there's really nothing to EMR, so I would move on to another endoscopic mucosal ablative therapy, either repeat RFA, or in these situations, a lot of times, this is where cryotherapy can be a benefit. Again, one of the benefits of cryotherapy is that you can adjust that length of cryogen exposure so you can get a little bit deeper tissue penetration. And that I found to be really successful in these kind of rescue situations. So in this patient, I might think about cryotherapy.
Using acetic acid?
Yes, I'm not. I haven't used that at all. I know that there are data out there just to support that.
Okay, thank you. So I wasn't sure what to do. I did not have cryotherapy in our unit at the time. I asked Dr. Shaheen, what should I do? I emailed him. I don't know if he's in the audience or not, but he advised me to obviously go back and look for any focal lesion. And obviously, if I saw a focal lesion, try to resect that endoscopically. He advised me to do an EMR, but don't EMR the full circumference of the esophagus because of risk of stricture formation. So he, in his anecdotal experience, he said in his experience, he's seen most of the cancers occur sort of between the 12 o'clock position to about the 7 or 8 o'clock position. And he said, why don't you EMR that, and label it quite well and leave a little bit of the circumference of the esophagus and biopsy that separately and then see what your path shows. So that's exactly what I did. So I went back with a band type EMR. I resected about from 12 o'clock to about 6, 7 o'clock. I labeled that separately, 12 to 7 o'clock. And then the 7 to 12 I left alone and I biopsied. So I did find the intramucosal cancer in the part that I EMR'd. Thankfully, and the margins were negative. I think I got incredibly lucky. Between the 7 to 12, it was just cardia and GE junction mucosa with inflammation, no cancer, no dysplasia. So I have brought this patient back again. Since then, I've done more targeted biopsies and I've labeled them quite well, 12 to 3, 3 to 6, 6 to 9, 9 to 12. And thankfully, he has remained cancer-free, no dysplasia, no cancer. And the last endoscopy I did on him was in March of 23, but again, he remains cancer-free. And I think he got lucky, I think I got lucky, and we've been able to, I think, eradicate his cancer. And now I'm sort of at a point where I'm doing sort of yearly surveillance endoscopies on him, so.
Question, do
Yes.
you have trouble lifting and doing EMR or ESD on patients that you've ablated? Because that picture, the initial picture looked a little bit like the tissue looked kind of sticky there and looked.
Yeah, I did sort of a band type approach, the band approach, and that went pretty well. But I agree with you that if I had tried to maybe lift it, it could be scarred. It might have been technically difficult, but I tried the sort of the cap band approach.
Yeah, I found that, again, the depth of tissue destruction with RFA is just so superficial that you just don't really get a whole lot of submucosal fibrosis. So doing EMR after RFA like this, usually you don't have much of a problem, sucking up that tissue and really getting that good pseudopolyp, and that good band around a good floppy pseudopolyp that you could then resect. Great.
And last case. This is a patient I saw more recently, 82-year-old gentleman who has some comorbidities. He had some dementia. He has had a history of aortic valve replacement. He was admitted to one of our local hospitals for chest pain and a normal stress test. He was found to be anemic. His hemoglobin had dropped from his baseline for about 11 to 12 to about 7.5. Cardiology was consulted because GI was consulted also because of his anemia. Obviously, we had concerns about doing any sort of procedures on him, and cardiology workup was done. Thankfully, his EF was not bad, 45%. He had been cleared for endoscopic workup. So he had no prior EGD in the past. He had a colonoscopy about 5 years previously. He undergoes colonoscopy was a poor prep, unfortunately. On EGD, he's found to have Barrett's with ulcerated area. In the Barrett's, very concerning. Biopsies show superficial fragments of at least intramucosal adenocarcinoma arising in the background of Barrett's esophagus. So he comes to me for an EUS, and I see that area on the top left endoscopically that looks very abnormal. On EUS, it was a little difficult to tell. Endoscopically, I couldn't define the borders, but the depth I felt was T1B with submucosal involvement of probably cancer. Thankfully, he has no cross-sectional imaging, did not show any evidence of any metastatic disease, nothing in his lungs, no lymphadenopathy. So he goes to see surgery. Surgical oncology find him to be a very poor surgical candidate given his age and comorbidities, and he is sent back to me to see what can you do. Is there anything you can do short of surgery with an endoscope for this gentleman with Barrett's with intramucosal cancer? Dr. Conway.
Yeah, so this is, again, a scenario that we encounter not uncommonly. And this is really where a multidisciplinary approach is critical in these patients. We certainly work very closely with our medical and surgical oncologist colleagues and think about these patients. No patient is really a good candidate for an esophagectomy. Frankly, it's such a terribly morbid procedure, and it's commonly these older folks that end up getting cancer. So this is a common scenario. I'll tell you that when you look at nodules within Barrett's, The first thing to do when you see ulceration like that within Barrett's is, of course, to put the patient on high-dose PPI and give them some time to heal as much as they can before you bring them back to do their EUS. I think that's a very important thing. The second thing, when you do your EUS and a lesion appears to be a T1 lesion, it's difficult for us to tell T1A, meaning not invaded through the muscularis mucosa, versus T1B with some mucosal invasion on EUS. That's really a very difficult thing for us to tell. Most of those patients should really then go on to EMR, and based on that EMR specimen, it's a pathologic staging of, is the patient truly T1A versus T1B? T1A patients have a very low risk for nodal metastases, less than 5%. Those are typically handled endoscopically. With endoscopic ablation. Patients that have T1B disease can have a much higher risk of nodal metastases, even if they're not seen on imaging, up to 30 to 50% in many of the surgical case series. So those are patients that may need to go on to some kind of further therapy, either esophagectomy or even sort of adjuvant chemotherapy and radiation. So can anything but be done endoscopically? Ideally in this patient, we would want to do EMR or ESD on this lesion. A couple things worry me a little bit about doing that on this lesion. The lesion looked pretty sizable. I don't know how, maybe 2 centimeters?
It's more like 3-4 centimeters.
Okay,
Again, the borders were hard to tell. There was ulcerations on the surface, so things that were not looking favorable for endoscopic resection.
Yeah, there's poor margins. It's pretty large. It seemed to be ulcerated and depressed centrally, which again makes me worry. There are some recommendations coming out very soon, if they've not been published, on EMR versus ESD, specifically in esophagus, and things greater than about 2 centimeters in size. You should really think about ESD rather than EMR, because you're more likely to get an en bloc resection. In this patient, I would say, just because of those endoscopic appearances, it's probably not the best candidate for ESD, which would be where I would go. We are lucky at Wake to have a couple of my colleagues, Dr. Darius Jahan and Rishi Pawa, who both do ESD. I would probably review the case with them, have them look at the pictures endoscopically to see if they'd be willing to try ESD. But that would really be the only thing. Again, with that centralized ulceration and depression, not the greatest candidate.
Is there any role for cryo in this situation?
That's a good question. Not really any good data to support this. For strictly palliative reasons, you could potentially do cryo. You would have to let the patient know that it would likely not be curative. It is very difficult with cryo to truly judge how deep you're going to get that tissue ablation. Mm-hmm. But I have had some patients who are such poor candidates for anything, even chemotherapy and radiation, and the medical and radiation oncologists come to me and say, is there anything you can do? This patient just doesn't want to go through anything. I could certainly try cryotherapy. I think it's very safe, but I would probably counsel the patient that it is more likely just to be palliative rather than curative in this situation.
Great, thank you. So yeah, all those things, we actually had a multidisciplinary meeting about this patient, and I reluctantly agreed to do an ESD on this patient. The borders were really hard to tell. You can see on the left panel, I kind of marked out as best as I could tell where the abnormality extended to, but admittedly it was very difficult. I was not thrilled about this case. I did do an ESD. The submucosa was very abnormal and decent amount of bleeding. It took me about 2 hours or so. Thankfully, he made it through the case. Unfortunately, the pathology was actually not surprising to me. It was invasive adenocarcinoma in the background of Barrett's. His margins are positive. The deep margin was positive. I was disappointed, but honestly not too surprised, because I felt like I was literally cutting through tumor in the deep submucosa. So the pathologic stage is at least a PT1B. So he's seen oncology. That's kind of where we are right now. There's discussions. Obviously, he's still got tumor in there. I think I debulked as much as I could safely. I hope I helped him. I'm not sure, but there are discussions about proceeding with either radiation alone or chemo and radiation. So that's literally where we are right now with this patient. but not the best case in retrospect for ESD. But I was kind of like stuck, and I'm like, I feel like I had to offer him something. So anyway, that's what I did for this patient. But
you know, we often are stuck, and we often want to offer our patients something, and I think that's one of the when it comes to medicine, that's a bit of the art of what we do. And as long as the patient is appropriately counseled on what they can expect with the therapy that you're going to give them, I think it's very reasonable to try that. You know, the other thing to remember also with, with chemotherapy and radiation, in our series at Wake Forest published years ago, about 25% of those patients had a complete response to just chemotherapy and radiation. So there is a role in some of these patients that are higher risk for surgery for chemotherapy and radiation and then surveillance. Now, 25% is 25%. It's not 100%, obviously, but there is a significant minority of these patients that actually can get away with avoiding surgery. So we do a fair bit of that, as well as surveillance after just chemotherapy and radiation.
yeah. Well, thank you so much. I'd like to thank the panelists. So those are all the cases I have. And thank you for this wonderful session, Bill. Thanks.
Thank you, everybody. Have a great trip home. Safe travel. Thank you. Come back next year.
Thank you. Awesome. Yeah. Thank you. Yeah. Yeah. Thanks. Great talk.
Hey, nice to meet you, Jason. Good to see you.
One thing I want to know about biotherapy for low-risk cancer. Me and Pete called me about literally last week. I hadn't heard really anything about
Thank you.